All right, so hopping back in to human body, we just talked about the axial skeleton, right? That's going to be your skull, or I'm sorry, yeah, your skull, your spinal column, and your thoracic cavity or your thoracic rib cage, okay? We talked about it contains your brain, your central nervous system, and it protects those major vital organs. They all work together to form that, that central nervous system highway. Everybody's good with that recap, right? All right, so the other part or the other section of your skeleton is going to be your appendicular skeleton, okay? This is gonna be the stuff, it would be nice to have, but we can live without it, right? It's not vital, it's not essential to us actually living and breathing, okay? So these are gonna be all of your extremities, right? Your arms, both of your arms, your upper extremities, your legs, your lower extremities, and also includes your pelvis, okay? So really quickly, we'll talk about joints. What is a joint? The medical definition of a joint, please.
Where two bones meet.
All right, so yeah, we kind of talked about that earlier, right? Where two bones come together, they meet, they're not gonna be fused together, right? But they come together to a point where we can allow some connectivity and some movement. All right, so give me some examples of some joints. So your elbow, your shoulder, right? I can freely move this. Your jaw, all right, yeah, your hips. So where your lower extremities connect to your hips, your pelvic girdle. Your phalanges, your fingers, right?
Knees.
Wrist. What else?
Knees.
No, not technically. No. All right, so knees and ankles, toes. All right, so anything that can bend or freely move like this is pretty much going to be where we have a joint, okay? We've got two types of joints. We've got a ball and a socket. Okay, so that's going to be your shoulder, right? I can move it any which way. I can move it up, back. I can do it in a rotating motion, okay? And then a hinge joint is going to be where you're only allowed to extend and flex, okay? So like your elbow is a hinge joint, your knee is a hinge joint. I can really only move that backwards and forwards. I don't have that circular free motion. All right, so this is an example of a ball and socket, if you can understand why. Okay, we've got the socket here, the ball here, and that's typically how they're going to be connected at those particular joints. And then just kind of the hinge joint, just backwards and forwards. Everybody good with what joints are, where they are, the different kinds? Yes, ma'am.
Isn't there one other one like a cell?
That's the name of it, but it's not like a particular type. You're talking about the one up here and the shoulder?
Yes.
Yeah, we'll get to that. All right, so your upper extremities, okay, we are going to refer to, you might hear it referred to as a limb, like an upper limb, an extremity, an arm. But your upper extremity is going to be from your shoulder, like so your socket up here, all the way down to your distal fingertips, okay? So, is this what you're talking about, the acromioclavicular joint? No.
I just thought I learned about every type of joint, but now I think it's more of a yeah.
Okay, I'll look into it, but for this curriculum, just the two, yeah. All right, so the upper extremity, so again, guys, the shoulder girdle is gonna be where your shoulder kind of comes together to the thoracic cavity or the rib cage, if you will, and it connects, but we have that extension down to the fingertips, okay? So part of that is gonna be your clavicle, all right, guys? You have these bilaterally. All right, what are these also referred to as? Your collarbones, okay? These are very easily broken. They're a very commonly broken bone, especially in like contact sports, okay? Because there's not a whole lot of kind of cushion there or any kind of padding there. If you get struck right here in the collarbone, it's kind of right there, just underneath the surface of your skin. So there's not a lot of protection It's very easily broken. All right, so we have these bilaterally. And then we are going to have in the back, right here, okay, so here's your clavicles. And then also making up the shoulder girdle, we have our little, sometimes we call them angel wings, or sometimes we call them shoulder blades. But yeah, these are going to be your scapula. You have these bilaterally. Okay. And then you are going to have your scapula and your humerus bone and your clavicle all come together to form this shoulder joint up here. Okay. So this long bone right here in your upper part of your upper extremity, it's going to be called your humerus. All right. It's easy to remember that this is your humerus because what happens if you hit a specific nerve bundle on your elbow? We call it the, oh, I hit my funny bone. Haha, funny humerus. Okay, so that's what the funny bone is. It's a nerve bundle right there that's not very, like if it's bent or whatever position it is, it's not very well protected. So if you hit it, that's where you get that just feels weird, it hurts, weird sensation. Okay, so now you'll remember that this is your humerus. All right, we come together at that hinge joint at your elbow. And then we have two bones that comprise your forearm. Okay. So again, remembering the anatomical position, if we're standing like this, all right, your lateral bone of your forearm is going to be what?
The radius.
Your radius, the thumb side, all right? So your bone that is on the kind of the side of your thumb, that's going to be your radius. You have a bone that kind of mirrors the side where your pinky is. That's going to be your ulna. Right? So based on your anatomical position, the lateral bone in your forearm is going to be your radius. The medial bone in your forearm is going to be your ulna. And guys, when we move forward, I think even in this chapter and with patient assessment, it's going to be easy to remember what side your radius is on because we also obtain a radial pulse right here. We're going to touch an artery right here that runs alongside that radius bone. And that's going to be where a lot of times we're going to check for a pulse for a heart rate. So we're checking a radial artery. It runs alongside your radial bone, okay, the thumb side. All right, so is everybody good with the humerus, your elbow joints, your ulna, and your radius? All right, so we're gonna move down into the wrist, into the hand, because again, down to our distal fingertips, that's the entirety of our upper extremity. All right, so these wrist bones, again, you're not gonna have to know every single one of them. I just want you to know that these several different bones that comprise your wrist joints, those are going to be your metacarpals. Sorry, carpals. Okay, so if you ever heard the term maybe like carpal tunnel syndrome, okay, that's specifically dealing with the nerves and the ligaments and everything right there in your wrist joint that are surrounding your carpals. All right, these long bones in your hands. All right, so your palm and the posterior part of your hands, those are going to be your metacarpals. All right, so from your wrist joint to kind of where the hub of your finger starts, these right here are going to be your metacarpals. All right, and each finger is going to be a couple different things, right? You can call them phalanges. Anybody watches Friends? Regina Phalange. Nobody gets it. All right. So they can be phalanges. All right. They can be digits. All right. Each one of them individually is a phalange. Each individually is a digit. Obviously, guys, there's kind of different terminology. This is going to be a thumb. your pointer or your index finger, your middle or your bird finger, whatever, right? Your ring finger and your pinky finger. So that's still kind of how we refer to if you've got a broken middle finger. That's what we say. Middle finger's broken. Okay. Everybody good with the wrist and the hand? Okay. Technically, yes. All right, so again, the pelvis is considered the appendicular skeleton as well. All right, so we have two major bones on each side, bilateral, right? We've got the ilium, the ischium, and the pubis, and then they come together right here. Again, we talked about this connective cartilage ring in the front part of the pelvis called the pubic symphysis. All right, again, this is going to be connective. It's going to help everything come together. It's also going to be a shock absorber as well. It's going to allow for movement and some flexibility. Okay. So the top part right here, like the hip bones that you feel when you palpate right here, those are going to be your iliac crest. All right, this nice kind of curved, smooth component on the inside of the bones, the medial aspect of the bones are going to be your ilium, and then your ischium are going to be right here. You might hear these referred to as your sit bones. All right, so along with your ischium and your sacrum, this is what supports your weight when you sit, right? Like in a seated position. That's why we're able to sit upright and we don't like collapse and bones don't break when we sit down. All right, so iliac crest, ilium, ischium. All right, so why do we have a pelvis? What does it protect? So we talked about the bladder, right? We do have a bladder. It sits kind of right here in between the pelvis. All right, but more importantly, we have major vessels, those great vessels that I was talking about. Okay, we're going to talk about the circulatory system, but anytime you see something depicted as a red tube, if you will, that's an artery. Anytime you see a blue tube or a blue line, that's a vein. Okay, these are essential to make sure that our circulatory system is working, that the blood is going where it needs to be, that these tissues, these cells, these organs are actually functioning and can live and can thrive. All right. So we've got two major big veins and arteries that what we call bifurcate. They kind of split off right here and go down and supply your blood to each individual leg. That's a major source of what that pelvis is protecting. That's why it's not necessarily a good thing if we have a fractured or a dislocated pelvis. Again, what happens to bones when they break? How do they appear? Sharp, jagged, pointy, right? If any of those bones pushed into, all right, those great vessels, what do you think could happen? Internal bleeding, right? That blood's no longer going to be contained in that tube where it's supposed to be. It's going to leak out. It's not going to get to where it needs to go, and patients can die from that. All right, so a fractured pelvis, an unstable pelvis, a dislocated hip, anything like that can be very detrimental to a patient if we don't handle them in the correct way and if we don't treat them the correct way. We'll get to that during trauma. But just know that you've got those two major vessels right there that can pose some serious problems if we have any structural instability to the pelvis. So the iliac crest. Yeah, like what you can actually palpate, what you can feel right there. So the pubic symphysis, Oh no, the pube, like the pube is part of the bone right here. This is just going to be the anterior part where they kind of come together. Everybody go with the pelvis?
Is the sacrum part of this?
Technically, yes. But it does help kind of serve as like the back circular aspect of the pelvis, but it's technically part of the spine. All right, moving on to the lower extremities, your legs, okay? So you notice here, this is where our hip socket, okay? We're gonna have that ball and socket joint, excuse me, for the pelvis. All right, we are going to have our lower extremity. Oh, there's not a picture. We're gonna have our lower extremity connected to our pelvis by our femur. Okay, so bilaterally, this really, really long bone. All right. This guy right here, this is going to be your femur. Okay. Notice we kind of have like it kind of protrudes up here. That's going to be called the femoral hip. That is where it's actually going to form that ball and socket joint to connect to the pelvis. All right, you'll notice the same thing up here for the humerus. This is the humeral head. That's where it's going to have the ball and socket joint for the shoulder. All right, guys, why is this the longest, most densest bone in the body? Yeah, day in and day out, every time we stand up, every time we walk, every time we run, all right, that is directly bearing all of our body weight, right? It has to be able to support our body weight and to allow for that movement and that motion, okay? So we've got our major big femur right here, and then we are going to branch off down here to the lower part of the lower extremities. We've got two bones. So it's the same as the upper extremity, right? One big, thicker bone and then two smaller bones. All right, so down here, the medial bone, right, the one that's going to be closer to the midline of the body, is going to be your tibia. You'll notice it's a lot thicker. It has a little bit more to do with that supporting of the weight. But the medial bone of the lower part of your lower extremity is your tibia. You kind of got this like little chicken wing guy on the side. He's a lot thinner, a lot flimsier. That's going to be your fibula. That is your lateral bone on the lower part of your lower extremity. All right, but we have our femur and our tibia and fibula connected via a joint, right? So here, particularly in the knee, we actually have a bone that is part of the joint. We don't really have that extra bone in an elbow joint, right? But we have what's called our kneecap. You can hear that referred to as that. It's this little triangular shaped bone, okay, that provides support and protection. But its technical fancy pants term is the patella. All right, so your kneecap is your patella. That's going to help form that knee joint. You guys can feel it on yourselves as long as you don't have like your muscles tensed up. That little triangular bone, you should be able to kind of like squish it around and move it a little bit. Right, it's got some free range of motion. Kind of.
Is there no like elbow joint?
It's just that bursa fluid. Okay. So everybody good with the femur, the patella, the tibia, and the fibula. All right. So moving down to the foot, guys, it's very similar to the terms that we use for the hand bones. Okay. So you've got your big heel bone back here. That's going to be your calcaneus. All right. The longer bones that comprise like the length of your foot, all right, to the hub of where your toes start, those are your tarsals. All right, so remember they're metacarpals for your hand, they're metatarsals for your feet. And then again, each individual toe is a phalange or is a digit. So those are pretty similar to compare to and to remember the names. So just remember tarsals for toe, your toe is on your foot. So the tarsals are located in your feet, carpals are in your. Okay. You've got the medial and the lateral malleolus. You will refer to these guys as the little bony circle on the inside and the outside of your ankle. These are the ones that if you like, I might show my age with this, but if you like knock it with one of those scooters, remember like the razor scooters, and you would hit, that's like the dead spot right there. You've got your medial malleolus and your lateral malleolus, these little circular bones.
Man, you're that old?
Remember, I'm in control of your grades. All right, so again, guys, we've talked about the skeletal system. It provides shape. It provides that upright kind of posture. It allows for movement, right? Calcium and red blood cells inside of the bones, that's a major component as to the function of bones as well, okay? Especially that red blood cell supply. All right, so yes, our bones help give us that upright posture. Yes, it helps give us that movement, but we've got to have some additional things connected to those bones to help us move, right? So now we're going to talk about the musculoskeletal system. So again, it does do some of the same things, upright posture, you know, give us a physical appearance. It also helps protect vital organs as well. Okay, because muscles are, and depending on where they are in the body, they can be pretty dense. They can serve as a very good, like, kind of shock absorber and some cushion before we get to those vital organs. All right, so they kind of do the same thing in different ways as the skeletal system, the bones do. All right.
So is this just the muscular system of the bones, or is this including bones?
So the musculoskeletal system is how they kind of work together. So there's separate like landmarks, but together they create the musculoskeletal system. Okay, so all throughout your body, there are 3 different types of muscles. Okay, what are they? Cardiac, skeletal, and smooth. All right, where do you think we find cardiac muscle? In your heart, guys. That is the only place in your body that we will find cardiac muscle. All right, the components of your cardiac muscles in your cell are super, super crazy cool because they do this thing called automaticity, where they create their own electrical impulse. Right? We'll talk about that when we get to the heart and the cardiovascular system. But cardiac muscle is only found in the heart, nowhere else in the body. Okay, so your skeletal muscles, what else might you hear them referred to as? Okay, so they are voluntary muscles, yes. What does that mean? What does voluntary muscles mean? I can control them, right? Give me an example of a voluntary or a skeletal muscle.
Bicep.
Everybody went straight to the bicep. All right, so your bicep, right? So let's say I have, my nose is itching, all right? There's a lot of things to go into that small, simple fact that my nose is itching. My sensory nerves have to be working that are, you know, supplied to my nose that feel that itching perception, right? My brain's telling my body, or my body's telling my brain, hey, this itches. Then my brain turns around and says, oh, hey, this isn't a very pleasant sensation. So bicep muscle, I need you to flex to bring your upper extremity, all right, to bring your pointer finger out to scratch your nose and make that itching sensation go away. I can control that muscle, that bicep. I can tell it what to do, right? You know, that much thought goes into just simply itching your nose. It's crazy. But on the other hand, if I'm sitting there trying really hard, like, I don't know, taking a picture or something like that, I can feel my nose is itching, but I'm like, nope, 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 can't scratch it, gotta leave it alone, it'll go away. I can tell my bicep muscle, hey, chill out, I don't need you right now, I don't need you to itch my nose. I can voluntarily tell it what to do and what not to do. Yes, ma'am. Yes. All right, you also might see these referred to as striated muscles. That's just based on the way that they are look in appearance. So striated, skeletal, know that those are voluntary. I can control, I can will them to do, for the most part, whatever I want to, right? Where else do I find voluntary muscles or skeletal muscles or striated muscles? Okay, so your face, if I'm trying really hard not to laugh, I can tell those muscles not to, you know, start giggling or smile. Where else? Legs. Guys, every time I just like take a step and pace around up here, like that is my brain and my muscles and my nerves communicating back and forth in that nanosecond for me to just willingly just move around. Right? Okay. So, smooth muscle. What is this? It is involuntary. Meaning what? I can't control this stuff. Where am I? What's going to be a muscle I can't control? Where am I going to find that? Okay, so a big one is in your intestinal tract. All right. So we just ate lunch, correct? Are we having to actively sit here and say, digest, digest, digest? No. My body is doing its own thing. There are smooth muscles all in my intestines that are doing a motion we call peristalsis, like a wave-like motion, and it's just gradually bringing that food through the intestinal tract. It's doing its thing, it's doing its job, and I don't actively have to sit here and be like, okay, peristalsis, peristalsis. It just happens. I can't control it. I can't, on the other hand, too, after I ate lunch, I can't say, okay, intestines, I need you to chill out. I don't want you to digest my food just yet. It does its own thing. I can't control it. Where else do we find smooth muscles? Okay, in the
Your
stomach.
heart.
Yep. Ish.
The
yes.
heart.
So, kind of, yeah, cardiac muscle is involuntary, but it's kind of its own category. But it is involuntary. I can't control it. You're right. Where else? Yeah, in your vessels. Okay, so through a crazy chemical and signal and messaging reaction, my brain can tell my arteries and my veins, there's a muscular component, especially in the artery, to say, hey, I need you to contract, and it makes the hole smaller, and that raises my blood pressure. Or I can tell you that it tells my muscles to relax inside of my arteries, and that lowers my blood pressure. I can't control that. Right? I can't say if it's like, especially if it's a stressful situation, we'll get to that when we'll talk about epinephrine and adrenaline. But that's how you have those physical changes in your body. All right? If I have a really, really, really scary moment, I cannot will my muscular component of my artery to say, hey, don't constrict, chill out. I don't want my blood pressure to go up. It does it automatically. I can't control it. Okay? So smooth muscle is involuntary. You find that in organs, so they can do their job without us telling them what to do. Skeletal muscles, striated muscles, they are voluntary. That's going to be your extremities, you know, willing yourself to take a step, itch your nose, do whatever you want to do. And then cardiac is going to be specifically to the heart. Okay. Anybody know where we find kind of a dual, smooth and, okay, so specifically where in the pulmonary system?
Is it your
So your diaphragm. All right, we'll get there in just a little bit, but you can kind of control to a certain extent your diaphragm, right? Because when you take a nap or when you go to sleep or even sitting in here just listening to me talk, are you actively having to say, okay, breathe?
No.
Well, I know, now you are. Breathe. No, we just kind of have that, you know, it does its own thing, especially when you sleep. You don't have to think about breathing, it just happens. But on the other side of that coin, if you jump into a pool, right, and you're going down to the deep end to pick up the dive stick or whatever it might be, you can tell your diaphragm, hey, I know we really want to breathe right now, but I don't want to drown, so I'm going to let you hold off on that respiration. Okay, so to a certain extent, guys, you can't hold your breath forever. Obviously, that automatic nervous system starts to kick in, but to a certain extent, we can control the diaphragm. All right, guys, I'll go over the major muscle groups that you need to know, okay? We already talked about the bicep. That's going to be this big muscle right here, okay? You need to know the trapezius muscles, okay? These are going to be the muscle groups that are bilaterally on each side of your neck on the posterior part, the anterior part as well. We need to know those because we do a certain part of our assessment there sometimes. What do we do right here? Yeah, this is where we can give a painful stimuli to see if our patient is truly unconscious, unresponsive, or are they a little bit awake, right? Again, I grew up with 4 brothers. They would just randomly come up behind me and like just grab my trapezius muscles and squeeze, and it like brought me to my knees. All right, so when we get to patient assessment, I'll show you how to give a true painful stimulus at the trapezius muscles. All right, so you've got your pectoral muscles. All right, why are these important? What do these help with? So a lot of stuff we do, they kind of integrate with these upper extremity muscles. But more importantly, how do we use these? Or what do we use these for? Breathing, right? We have to use our pectoral muscles to try to open up that rib cage, allow that room for those lungs to expand. So it does help with breathing, guys. We don't use them a ton when it comes to breathing. If we see somebody excessively using their pectoral muscles to breathe, we got a problem. Okay, but just know that they're there. They help with breathing. Let's see, what else do you know? All right, so the deltoid muscle. This is going to be important because when you start to give intramuscular injections, this is typically where you're going to go. Okay, right here in the deltoid muscle. You've got your abdominal muscles. I don't need to know a ton of these. Triceps are going to be back here behind your arm. Okay. You got your gluteus maximus. What is that? Your buttocks. All right. That is also another site for an IM injection sometimes. Okay. You've got your quadricep muscles, right? These big groups right here on the anterior part of your thigh. You specifically have one called the vastus lateralis, and it runs right here on the lateral side of your body. Imagine that. You need to be very familiar with the vastus lateralis because that is an injection site of one of your medications that we will talk about. All right, so your vastus lateralis is right here. It's part of your quads. It's a big, nice, dense muscle. It's there for a reason. And then, guys, other than that, you don't need to know a ton of these itty-bitty, like, smaller groups when it comes to kind of what we really do as a first responder. Okay. You also have, we talked about those intercostal muscles, right, in between the ribs. Those will come into play when we talk about respiratory as well. They help us breathe as well. All right. So also another important factor to remember, a byproduct of movement is what? Heat. All right, so that's why if you're doing any type of like physical activity, if you're going to the gym, if you're going hiking, if you're vigorously cleaning your house like I did during quarantine, right? those muscles, the action of flexing and extending those muscles, tensing them up and moving them back and forth up against each other, all right, that friction, that motion, byproduct of that is heat. So that's why your body temperature starts to elevate when you go to the gym. You start to get that hot flush feeling. You start to have, you know, you're breaking that sweat and knowing that you're really getting into a good workout or whatever. So understand that a byproduct of movement, especially when it comes to the muscular system, is going to be heat. Do you guys ever watch like Survivor shows like Bear Grylls or like Naked and Afraid or whatever? That's every survivalist will tell you, if you're in a cold environment, never stop moving, right? Even if it's just kind of standing up, going from side to side. Be careful not to move too much so you don't like break a sweat, because that can kind of have the reverse effect. But you're just constantly moving because, again, we're moving those muscles, we're making that friction, we're causing our body temperature to maintain that heat that we need to live, okay? Question, comments, concerns on the musculoskeletal system. About to jump into the respiratory system. Very good?
Not at the moment.
I have a quick question.
Yes.
Interpreted.
Yes, yeah, go ahead.
Can you state which the diagram of all the muscles that I think was on the previous slide? Can you just say again which muscles we needed to, or which ones we didn't need to know?
The ones you need to know, sorry.
Yes.
Yeah, so you'll need to know the trapezius muscles, pectoral muscles, know that we have intercostal muscles. I mean, we have muscular components to every location of our body. So we have some in our neck that will play, in fact, with respiratory. Your abdominal muscles, your gluteus maximus, your biceps, your deltoid, your triceps, your quadriceps, particularly the vastus lateralis right here. Those are the major muscle groups that you need to be aware of.
Okay, thank you.
All right. Ready for respiratory. Get a little deep here, okay? All right, so with the respiratory system, all right, it's broken into the upper airway and the lower airway. What do we use our respiratory system for? Breathing, right? So all of these aspects of the anatomy of our airway is going to accomplish that end goal of breathing. And at the very end of the day, having vital gas exchange happening inside of our lungs. All right, we'll get there. All right, so your upper airway. What do we got in our upper airway? What's that composed of? Okay, so your nose. Okay, so your nostrils or your nares, we have those bilaterally. Okay. All right, so your sinus cavities do come into play. How are they separated? Why do we have a right and a left nostril? What separates the two? Your septum. All right, so in terms to definition and anatomy, a septum is going to be something that divides something into kind of two halves or two sides. So you've got a septum here, we have a right nostril, we have a left nostril, all right? And then we are going to go through our nose, into our nasopharynx. All right, guys, that's just kind of like the reservoir where if we breathe in through our nose, that's where the air kind of goes, it gets funneled down, and then we kind of push it down into our lungs, okay? So we have our mouth, and again, we go back to that kind of collection area, the oropharynx, and then we're all going to tunnel it and funnel it down into our lungs, all right? What's important to know, how is our nose, our nostrils, different than our mouth when it comes to breathing?
The nose has like filtration options.
How?
Because like there's small hairs and stuff that go through the particulates.
All right, so we have hairs in our nose for a reason. Okay, so they do three different things. All right, they filter. All right, so if you're breathing in through your nose, those nose hairs will catch those itty bitty pieces of dust and dirt and debris. It'll kind of hold on to them because they stay nice and moist in there. It's not very lovely to think about, but they're there for a reason. And it'll hold on to it, and eventually it'll get rid of it through what? Splinters, right?
When you sneeze,
Yes, okay, so when you sneeze, or they will, form bugs. That's what we call it in the house. Hey, you got a bug, right? We'll eventually blow our nose or get rid of those, and that's one way that it can help filter the air that we're breathing, okay? What else does it do? Smell. Okay, so yeah, our sense is there for smell, but it doesn't really affect our respiratory system.
In addition to traffic, it protects us from inhaling things that can be bad for us, right?
Okay, so yeah, the kind of the sense of smell plays into that as well. But yes, ma'am.
Like when you with your nose, it's usually like more involuntary.
Okay, can be, yeah. So the hairs in our nose help filter. Okay, so it filtrates. It also warms, right? Just that movement of the hair. It takes longer to go down into your lungs, so it will warm the air a little bit better. And it will also humidify the air a little bit better. Okay, so that hair in our nose, in our nostrils, is there for a reason. That's why a lot of people like advise against getting your nose waxed. Y'all seen that? Like that's going viral lately. They'll put the wax up there and like stick it in with a Q-tip and then like rip out all of your nose hairs.
yeah.
A, that's got to be dreadfully painful, and B, you need those things. So, just fun fact of the day, huh? Oh yeah, yeah. All right. So the nose hairs filter, they warm and they humidify. Okay. Also important to know, both our mouth, which is part of our respiratory system, breathing in, and our nose, they're lined with what? Mucous membranes.
Membranes.
Right. It's really, really important to know those mucosal membranes are there for a couple different reasons, right? It helps keep that environment what? Moist, right? That's what that the part of our airway tract is supposed to be nice and moist. And also, what happens with mucosal membranes? They absorb, right? We need to be very aware of this because once we put, whether it's a chemical or a drug, intentional or unintentional, if we have that come in contact with the mucosal membranes, the lining of our nose or our mouth, those mucosal membranes will absorb it, it'll take it, and it will eventually disperse it where? In our bloodstream, right? And once something's in our bloodstream, what does our blood come in contact with? Literally every aspect of your body. All right, that's how, if you take like a nasal spray for like allergies or something like that, that's how the medicine works. It gets in your mucosal membranes, it absorbs it, it puts it in your bloodstream, and it does its job. Okay, so remember, lined with the mucosal membranes, we can give drugs, intranasally, okay, into those mucosal membranes, but that's also how things get absorbed, either intentionally or unintentionally, through those mucosal membranes, hits in the bloodstream. All right, so we've got kind of like our reservoir system for our nostrils and then our mouth, and then we start to funnel down towards the good stuff down here, right? So our epiglottis, all right, what is our epiglottis? It is the blank to your esophagus, or I guess to your trachea, really.
It is the entry. It's the entry point to your esophagus.
Okay, so yeah, guys, I had some airway diagrams. I don't know where they went. I guess somebody stole them. But you have got two tubes right here in your neck. In your
And so the epiglottis is the flap that acts as the sort of blockage, so you don't have food or the liquid flow down to your trachea and into
Exactly.
your esophagus.
Exactly. Yeah, so you have got two pipes, two tubes in here in your throat and your neck. All right. Your anterior tube is going to be your trachea. Okay. So there's not a good like view of it here, But anteriorly, that is going to be AKA your windpipe. That's going to be the direct connection to your lungs. What is the only thing we want in our lungs? Air. Okay, I don't want any solid particles. I don't want any liquid particles in my lungs. It's not supposed to be there. It can do bad things. All right. Now that tube, guys, they rest like right up against each other. So the posterior, if you will, tube is your esophagus. Where does your esophagus lead? To your stomach. What do we put in our stomach? Food or solids and liquid, right? So because they are so close, because they butt up next to each other so close, we have the epiglottis, all right? The epiglottis, I like to give my nerdy reference, is a Gandalf to the trachea. Anybody get it? You shall not pass.
You shall not pass.
Yes. All right. So it's kind of like a floppy piece of tissue that every time, that's really enthusiastic, I like it. That every time we swallow, where am I taking things that I swallow? I want them to go where? My stomach, my esophagus, right? So what happens is every time we swallow, that epiglottis will kind of flop over and cover up the trachea. So that way, all of that solid and that liquid that I'm swallowing and trying to get to my esophagus, it doesn't cross over and go to my trachea and get down in my lungs, because that can be really, really bad. Right? So the epiglottis is Gandalf to your trachea. It flops over, it protects your trachea, it covers it, and it says, nope, no solids or liquids coming down here. You go to the esophagus.
How does it make a watertight seal?
Just the negative pressure and just yeah, it's just crazy cool. All right, so next time you guys are like inhaling and taking a drink at the same time, and you start to have that violent cough, what's happening there? Your epiglottis failed you, right? It didn't close over your trachea in time, and you started to what we call aspirate either that solid or that liquid into your trachea. What's your immediate reaction when it happens? A violent coughing fit, right? You can't control that, right? That is a hardwired defense mechanism by your body to say, oh my gosh, there's something trying to come in the trachea. It cannot be here. I don't want it in my lungs. All right, so we cough and we force all of that air out of our trachea to try to disperse or dispel that liquid or that solid, because we know it's not supposed to be there. It went down the wrong pipe. It went down the wrong tube. That's really what's happening. All right. So is everybody clear? We've got the trachea, Lord help me. The trachea that's anterior, esophagus is posterior, and to correctly direct air versus solid/liquid, the epiglottis flops over, protects the trachea when we swallow. Are we good with that? Okay. So now we passed the epiglottis, okay? We're starting to go directly into the trachea. So from this point forward, all right, or from this point down, this is gonna be our lower airway. Typically, the larynx right here is gonna be the dividing spot between your upper and your lower airway. What's contained in your larynx? All right, so your vocal cords, your voice box. If you go through to paramedic school, when you intubate, you're literally putting a breathing tube directly into somebody's trachea. All right. One way that we are aware we're putting it in the right tube, because sometimes we put it in the wrong place, right? We put it in the esophagus. It doesn't go in that tube where we need to because they're so close to each other. One way that you're trained that you're putting it in the correct spot is that you're visualizing that tube going through the vocal cords. All right, so the vocal cords are the gateway into the trachea. All right, so now we're in the trachea. We're going to talk about what it's made of, you know, all that stuff in just a minute. And we're going to come down to this little dividing point, okay? In a lot of the pictures, it looks like it's wearing like a little bathing suit bikini bottom. All right, so this is the carina. This is where we are gonna, that trachea is gonna kind of bifurcate and branch off into both sides of my chest, getting into the lungs. All right. So from this dividing point, we are going to branch out into these big tubes right here called the bronchus. You got your main stem bronchus. All right, you've got a right stem bronchus and a left stem bronchus. All right, these are going to be the pipes to go into your individual lungs. They start out, rather wide, and then they're going to start to funnel down to smaller, teeny tiny tubes.
So the creator is just the divide.
All right, so the further we go down, guys, we branch off into hundreds of itty bitty like little roots, kind of looks like roots branching out from a tree to cover all aspects of our lung from top to bottom. All right, so we're coming from the main stem bronchus or the bronchi, and we're going to get smaller and smaller, and we're going to get turn into bronchioles. All right, so bronchioles are the miniature version of bronchi. All right, so when we get down to these itty bitty bronchioles, we're going to branch off and have these little grape kind of cluster things right here called alveoli. This is where the magic happens, right? This is where we talked about that vital gas exchange. This is where that occurs. We have to get all of that air all the way down to our trachea, through our bronchus, to our bronchioles, to the alveoli. And this is where we have that oh so important CO2 and O2 exchange. Okay, so when we breathe air, okay, part of the content of the air that we're breathing in is what? What do we need? Oxygen, right? So in these alveolar sacs down here that are directly connected to the bronchioles, they are covered in teeny tiny, guys, microscopic, like a net-like vessels, both arteries and veins. They cover those alveolar sacs or those alveoli, and that's where we have that oxygen I'm breathing in. It gets pushed into my bloodstream. And once it's in my bloodstream through these itty bitty vessels right here, it can now go distribute it to the rest of my body.
So is this all like in the walls of the lung, or is it in the middle of the sac?
So inside the lung tissue itself, we have it kind of burrows into the lung tissue, the bronchioles, and then we have the openings inside the lung tissue itself with the alveoli. Okay, how do you think I can get those oxygen molecules from the air I breathe into my bloodstream? What do you think these have to be? The capillary beds.
Have to be wet.
So they are moist, yeah, they are very small, but they're very permeable.
Permeable.
There you go, permeable. That means it doesn't take a lot of effort for those molecules to pass through the walls of those capillary beds. All right, so that's how very easily the O2 molecule is pushed through the wall of that capillary bed into my bloodstream, and then it goes to the rest of my body. Okay, what was the other gas I mentioned? Carbon dioxide, CO2. All right, guys, what is this? So it's kind of like a waste gas, right? It's very acidic. We like a little bit of it to be in our body, but not too much, okay? So at the same time I'm getting those O2 molecules pushed into my bloodstream, I'm getting that waste, that acidic byproduct, that CO2, I'm getting it out of my bloodstream. I'm pushing it from my blood into those capillary beds, into the alveoli. And how do I get rid of that CO2? I breathe it out, I exhale. I force it out of those alveoli, up through the bronchioles, up through the bronchus, through the trachea, out of my body through exhalation. Guys, this happens every time we breathe. Isn't this freaking crazy? It's so cool. You don't have to think about it, right? all of that gas exchange getting down to that anatomy, going in and out of those capillary beds, going where it needs to be. It just happens.
So, have they done research on how the muscular active breathing triggers the gas exchange mechanism? Like, is it, like, how do they move together?
Like the muscular component, or what are you saying? What
Like-
triggers?
Like, how does it, I don't know, like, how does it know to do the, like, cellular respiration and then push the CO2 right there so that, like, it lines up perfectly with the, like,
It just
muscular
does.
component of
It's
breathing?
how it's hardwired. All right, so we pick up on those different levels in our blood, like the pH levels. If we have too much or too little CO2, the brain recognizes it and says, okay, we got to fix this. We got to get these levels right. And then that can trigger hypo or hyperventilation to like balance it out. Yeah, we'll talk about that, but it's just like
It's
crazy.
typical, it's a single exchange filter, right?
Yeah.
One passes this way, one
It's crazy.
passes that way. So you're not 100% either, right? It's more oxygen.
right.
It's
It's awesome. All
Instructor.
right, so question?
Yeah, just to kind of backtrack a little bit, was the trachea part of the upper airway or the lower airway?
It's part of the lower airway.
Okay, awesome, thank you.
All right, so guys, notice here we've got our lungs bilaterally. We notice that it's nice and covered by the rib cage, as indicated right here. Who is this? That's the diaphragm, okay? That's what's gonna separate the thoracic cavity from the abdominal cavity. All right, that is that muscle. It's in a normal state, it's kind of shaped like a little dome, like this, right? If it's nice and relaxed, that's how it's shaped. But when we contract, we pull the diaphragm down, and that creates what in my chest? Okay, so some extra space, but it allows my lungs to fill up because I'm creating a vacuum, like negative pressure, right? I'm just kind of helping bring that air in, helping my lungs inflate. All right, so that's going to be your diaphragm that we talked about is involuntary and voluntary to a certain extent. It is a major component as to how we are able to breathe.
So when you have like a punctured lung, it doesn't work because the vacuum
In a sense, yes. We're going to jump way into pneumothoraxes in a little bit later, but yeah, that's connection more so from the chest wall and the lung is now separated. It doesn't necessarily have to do with the diaphragm. The diaphragm can still be working, but the connection between the lung and the inside of the chest wall is severed in some capacity. All right, so guys, we kind of talked about all of this already. Everybody clear on the nose, the mouth, larynx, all of that upper airway stuff. That's how we start to draw that air into our lungs. All right, trachea, blah, 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 esophagus. All right, so where are all my pictures? Okay, so here is where the larynx is located. We have a specific kind of buildup of this cartilage to protect the larynx, and specifically this thyroid cartilage. What is that going to be called? Guys, it's more predominant now. Yeah, so your Adam's apple right here. Guys, this is built around your larynx to make sure there is an extra added layer of protection because it is the gateway to the trachea. So talking about the trachea, what's it made out of? Okay,
Cartilage.
some smooth muscle, but mainly these cartilage rings, right? Okay, so again, this kind of bluish tint is always going to represent cartilage in your book and in these diagrams. All right, guys, I do this another stupid analogy. Did y'all ever, like, if you lived in a dorm room or now, those laundry baskets that had like the metal spring coil in the middle of it, and you would just like fling it open, and that's how it stayed upright, were those metal coils. That's kind of what these trachea rings are, these cartilage rings are for the trachea, right? Because we talked about when that diaphragm contracts, we're creating what in my thoracic cavity?
Oh, okay, I get it. It's giving it structure because we pull vacuum it out.
right? So we're having that vacuum effect. My chest is opening, my lungs are inflating. I'm creating that negative pressure so I can breathe in and I can fill my lungs up. If those cartilage rings weren't there surrounding my trachea, what would it do under that negative pressure? It would collapse, right? So those cartilage rings help keep my trachea open and upright and prevent it from collapsing on itself every time I breathe in, because I create that negative pressure so I can expand my chest and my lungs can inflate.
Is that the
So no, the cricoid cartilage is going to be that first kind of ring right below your Adam's apple. That's actually where, as a paramedic, I can create a surgical incision and place a tube. I can cut through the neck right there. All right, so that's just a landmark for that type of airway that you can do as a paramedic. But that's going to be that main kind of opening right there that exposes that tissue that we can drop a tube in.
So can they replace those rings?
Honestly, I don't know. I wouldn't see why not. I don't know if it would be like a metal stent, but I'm sure they could artificially have it with something. Okay, so guys, again, this is just kind of another view. You see the cartilage rings. All of these itty bitty branches are your bronchioles. You've got your thicker bronchi here, diaphragm here. All right, lungs. Okay, what are your lungs? They're just empty sacs of air, right? They can't do a whole lot of motion and movement and expansion and deflation on their own. It is super, super essential that they are connected to the inner lining of our chest cavity to make sure that they're working, to make sure that they can expand and deflate, okay? So let's see, we have a right lung and a left lung, all right? Our right lung has how many lobes? 3. What are they? Upper, middle, and lower, right? Not a lot of like technical terminology for that. Okay, your left lung only has 2 lobes, an upper and a lower. Why? Who sits right here? It's kind of important. Your heart, right? It goes off to the left side of your sternum. So that middle lobe is non-existent in the left lung to make space for your heart. It's not shorter, it's just kind of got it, the lobes aren't as involved. I'll show you, there's a picture here. Surface area is almost the same. It's just the lobes are shaped differently. They come together differently, just to kind of make just like a little cubby hole for the heart. Yeah. Yeah. Insane. Don't squish it. It's purposefully kind of like got a little cubby hole to make room for the heart. So it doesn't affect the function of the left lung. It's made that way to accommodate the size of the heart. For the most part. Yeah, it's not like a drastically different on the left lung versus right. All right, so again, we've got the just sacs, empty sacs of air. That's what our lungs are. This pleura that we're about to talk about is super, super vital to make sure that in congruence with our chest cavity, we are able to actually open and close, if you will, our lungs to breathe, okay? So pleura is gonna be kind of like a smooth, a little bit sticky, kind of fluid covering on the outside of your lungs. And we also have it lining the inside of our chest wall, okay? The pleura that lines the lungs themselves and the chest wall, they come together to make kind of like a suction cup connection. All right, as long as that pleura is intact, every time I expand my chest wall is going to bring my lungs along with it. That's what allows our lungs to fully expand. And every time I, exhale, my chest goes down and it brings along the lung with it. As long as that pleural lining is connected to each other, that suction cup connection is there, I am able to move my lungs at the same time I'm moving my chest wall. Okay, do you have a question?
Yes.
All right, so again, when we're talking about a collapsed lung, for whatever reason, that suction cup connectivity between the pleural linings is not there anymore. So my chest could be moving, right? But my lung's not going with it. So it's not fully inflating and deflating. That's where we get a pneumothorax. Talk all about that in trouble. But that connection is separate. Okay. Everybody good-ish? Is anybody like totally lost? I know it's a lot. We start diving a lot deeper for respiratory and cardiology, but then we go back to kind of normal.
I don't have any at this moment, but I'm sure I'm gonna have some later.
Okay, that's fair.
So what pleurisy, right?
Mhm.
Is that like a tearing of that line?
So it can be a tearing, it can be an accumulation of too much fluid, which can eventually cause, like the weight of the fluid can cause a pneumothorax, can cause it to detach.
So you like having a million couple times when you said pleurisy,
Mm-hmm.
right? And they explained it like it was the chest was broken.
Mhm.
So you just-
It's very painful. It causes like that, the pressure in between the pleural lining, it causes like a lot of friction because they're not moving congruently. Yeah, it's just fluid buildup and doesn't feel good.
It's a long time.
All right, so guys, muscles of breathing. We're gonna go over this really quickly because we'll jump into it for the respiratory chapter. But in a small sense, we use a bunch of different muscles to breathe, right? What are some of the muscles we use to breathe? Huh?
Abdomen.
Okay, so we use our abdominal muscles a little bit, right? All right, not a lot, but we use it to kind of create that negative pressure to create more space. What else? Your
Chest.
pectoral muscles, right? Your chest muscles. We've got those intercostal muscles, the muscles in between your ribs. And we use a little bit of our neck muscles. Okay, guys, I should not be able to walk in a room and from across the room, count your respiratory rate. All right, if you're not having any difficulty breathing, if you're not having labored breathing, breathing in and out it's a very minute movement. It's not very big, right? So in very small moderation, we use those different muscle groups to help us breathe. If we see somebody excessively using any of those muscle groups, if I can walk in the room and you're breathing like that much exaggerated, I know we're having a bad day. If I can count your respiratory rate from across the room, we're not in a good spot. Okay, so if we see like excessive muscle use for those groups we just talked about, we call that accessory muscle use. And that is a big indication we're having difficulty breathing. All right, so we're going to jump into some definitions. All right, we got to know these definitions to know how everything works together. All right, but we're going to start with ventilation and respiration. What is the definition of ventilation? Right. So the actual physical moving of air in and out of the lungs. Just the physical movement, getting air in, getting air out. All right. The definition of respiration is going to be what? That actual gas exchange. Okay. We're ventilating, we're getting the air in there, but we also have to make sure we get down into those alveoli and we have that respiration occur, which is the gas exchange.
I'm so sorry. If you're in a good break spot within a minute,
momentarily. Okay. All right, so guys, can we have one without the other?
Well, yeah, but
No.
Technically, yeah, but is it going to last very long? Right? Can I have that gas exchange happening in my alveoli if I am not physically getting any air down there? No, I cannot have respiration without ventilation, right? Technically, I can ventilate, I can be moving air in and out, but it doesn't mean that that gas exchange is occurring. So I can have some ventilation without respiration, but that's not going to last long because eventually the patient is going to die because we're not getting oxygen and CO2 exchanging out of our system.
You kind of answered about, I don't know, because I was going to ask, so if you're bagging them, they're not breathing on their own, so they're going to kill.
No.
Yeah.
So you're ventilating the patient. Just because you're forcing air into their lungs doesn't mean that that chemical exchange is happening at the alveoli.
Right.
So you can be bagging them, we can be breathing for them, but we're not
But the
respirating
chemical
for
part,
them.
yeah.
Yeah, that's up to the body.
Is that the life support then, if the work is allowed?
There's a lot that goes into it, but that is part of it.
Are we gonna,
just thinking of the challenge, right? So the gas exchange, we're sussing up what oxygen. So you might give them extra oxygen.
Not exactly through like the blood component, but we do have a monitoring tool that can tell me the CO2 level.
Okay.
Yeah, but it's not through the blood. It's through we attach it to the
Then
tube.
you know the efficiency.
Yes.
Use that.
Yes, that's advanced level. When you guys get to AEMT, you can read capnography and utilize capnography, but that's not gonna. We'll talk about it absolutely, but that's not something you guys do at this level. Okay.
are we gonna talk it? Are we gonna talk at all about how COVID has been attacking the lungs or COPD or anything like that, emphysema?
Oh yeah, absolutely. When we talk about the respiratory emergencies, we're gonna jump into the problems with respiratory. Right now, we're just talking about how it works normally, but yeah, absolutely.
Gotcha, thank you.
Okay, so make sure you guys know the definition between ventilation and respiration. We can't respirate if we're not ventilating. We can ventilate a little bit, but if we're not having that respiration occur, the ventilation is going to stop because we're going to die. Okay, hold on 2 seconds. Pause recording for just a second. All right, so jumping back into the respiratory system. Okay, remember guys, we defined ventilation, we defined respiration. Got to have one to have the other, right? So just understand that this whole respiration process happens by diffusion. What is the global term of diffusion? Path of least resistance, right? We go from something that's highly concentrated through that really permeable membrane called those capillary beds that surround the alveoli. So we don't have a lot of resistance there. That's how they are able to like have those molecules free flow in and out of the circulatory system to the alveoli. Okay, we have to have that permeability. We can't have anything that's preventing or causing a lot of resistance at those capillary beds. Or what do you think is not going to happen? The gas exchange, right? If there's any effort required for that CO2 or that O2 molecule to go through those capillary beds, it's not going to happen. That's where we start to run into problems. Okay, we'll get there later. Guys, remember your brain stem. Your brain is a motherboard, but particularly your brain stem controls every vital function. It controls your respiratory rate. It controls how deep we breathe. It controls your heart rate, your blood pressure. Okay, so all of those little vital signs, those vital functions are carried out and conveyed through the brain stem. Okay, we're gonna jump a little bit into respiratory real quickly here. All right, So what does our body like to maintain globally? Homeostasis. What does that mean? Just a balance of everything. All right. So there are certain levels that we like our pH or our acidity, our acid levels to be. Just different fluid levels. All of these different levels have to stay within a certain range for my body and my brain to be happy. Right? Now, if we're having some trouble either getting the oxygen in my circulatory system to deliver to the rest of my body, or offloading, what other molecule? Carbon dioxide, that CO2, my brain starts to say, hold on, we're not at the right level and I need to fix it. Okay, the brain picks up on these levels through what? Okay,
So nervous system.
Okay, so yeah, in a sense, but it looks at these levels through the blood and the CSF, the cerebrospinal fluid, which is fluid that surrounds your spinal column and your brain. Okay, so if the levels in that kind of fluid are off, my brain's going to pick up on it. It's going to know exactly what levels are off, if it's too high, if it's too low, and my brain's going to go into that automatic, hardwired defense system, if you will, to fix it, to try to regulate those levels. All right, 2 of these are contained with the respiratory system. We have 2 alarm systems, if you will. All right, so the first one, our first line of defense, is going to be monitoring that pH level, which means the acidity. So when it comes to that carbon dioxide, if we have too much, what do you think my pH level is going to be? It gets kind of like, okay, so the actual number of my pH level is going to be a lower number, right? But that's its opposite. It means that my acidity level is too high. There's too much acid in my system. My brain's going to recognize that. That's going to be the first line of defense. If my brain notices there's too much CO2, I am too acidic, my first alarm system is going to be that's where it kind of triggers. That's where it picks up on it. But it's called the hypercarbic drive. Hyper, excessive, carbic, related to the carbon, the acid. And then that if we notice that there's too much CO2, that first line defense system is going to kick in. What do you think my brainstem is going to tell my body to do to try to get rid of that excess CO2? Breathe out. How? Right. It's going to automatically increase my respiratory rate. Why? Every time I breathe out, I get rid of what? CO2. So it's going to tell my body to breathe faster and to breathe more. So I'm exhaling more of that CO2. I'm trying to get it out of my system. So your respiratory rate will increase and you will actually breathe a lot deeper to try to blow off more of that CO2, get it out of your system. So that is the hypercarbic drive. That's the very next thing. So we said there were 2 alarm systems, right? This second one is kind of the understudy, if you will. You know,
What do you mean by like alarm systems? Like how is it? So it's like the medulla picks up on like the.
it senses that there's too much CO2, the pH level is off. And so that in turn, it interprets we have too much acid. I'm going to try to fix this by telling my respiratory system I'm going to increase my respiratory rate and my depth. Okay. So the understudy, if you will, for the hypercarbic drive is going to be the hypoxic drive. All right, what does that mean? Hypo, too little, oxia, oxygen. All right, so if that hypercarbic drive's not kicking in, like that hypoxic drive would be like, hey, I know I'm down here and I know I'm not as important, or, you know, like the first acting line of defense like you are, hypercarbic drive. I don't know why you're not kicking in, but yeah, we might have too much CO2, but now the hypoxia drive is saying yeah, I'm concerned about CO2, but also my body's not getting what? Oxygen, right? So we're actually more concerned, my brain's more concerned with getting that acid out before it is getting oxygen in, because too much acid can do a lot more damage than lower levels of oxygen can.
Does hypoxic drip also cause hyperventilation?
Yes. So the hypoxic drive will kick in. It will also increase the respiratory rate. It'll increase the depth. So yes, I'm also blowing off CO2, but I'm also intaking more oxygen. Remember that when we get to talking about another medical emergency later on down the road. Okay. All right, so going back to ventilation, the physical movement of air in and out, we have tidal volume, okay? What is that? What's the definition of that? So the amount of air that is moved in and out in one breath, okay? So that's my tidal volume. Who knows what the approximate average tidal volume for a normal average adult male is? That's what we're going to base all of the average numbers when it comes to levels are going to be after on an adult male. Okay, so half a liter, 500 milliliters is the average tidal volume that we take in and out for each breath. All right, now guys, out in the field, am I going to have a piece of equipment that measures exactly how many milliliters my patient's breathing in and out? No, we don't. If you're a respiratory therapist, yeah, they have stuff like that, but not on the truck, okay? What do I care about? What do I want to see that will tell me, I don't care what the number is, but I know that patient's tidal volume is sufficient, it's good. Okay, so if they're breathing normally, but more importantly, what?
We talked about these other muscles.
Probably the number of respiration.
Chest rise, right? I want to see equal adequate bilateral chest rise. If I see my patient's chest rising up and down in a normal fashion, I don't care about the number of the tidal volume. I know it's good for my patient, right? That chest rise tells me that that tidal volume is good.
Would you actually see a disparity?
If they have any thorax, yep, absolutely. All right, so know that it is 500 milliliters, it's half a liter average, but in real life application, I just want to see that chest rise and fall, and that tells me that's enough air movement. Okay. All right, residual volume, what is this? All right, so guys, every single time we breathe in, all right, all that air doesn't make it all the way down my alveoli. Every time I breathe out, I don't clear out every ounce of air in my lungs. What would happen if I did? It would collapse on itself, right? We talked about that pleural lining is kind of sticky, all right? So if every bit of air that was in my lungs left when I exhaled, everything would kind of like collapse and stick to each other. No, you can't. Like on your own, you can't will it. It's hardwired that you can't. All right, so your residual volume is that air that is inside your lungs that keep it nice and inflated every time you breathe out. You've got a little bit of reserve in there. Okay. Now, you cannot, your body won't let you forcibly breathe every single ounce of air out. It just won't. But something can happen that can deplete this residual volume significantly. Not drowning.
Wind knocked out of you.
You get the wind knocked out of you, right? Guys, has anybody never had this happen to them before? It's a horrible feeling, all right? What happens is we have some external trauma and it pushes our diaphragm. It forces our diaphragm up. So a lot of times if you get like punched in the gut and you're not bracing yourself for it, that diaphragm gets punched up. And then all of that air gets forced, most of the air gets forced out of the lungs. Kind of, yeah, kind of. So what is your immediate reaction when you get the wind knocked out of you?
Try to catch
have
your
like
breath.
a panic attack, right? It hurts and you start hyperventilating like crazy. Because what's the brain thinking? No, 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 no. I need that residual volume. I don't want my lungs to collapse on itself. Hurry up, fill those lungs back up. Don't let them collapse, right? That's why you have that sheer panic and you're breathing really deep and really fast to make sure that your lungs stay inflated and that residual volume gets replaced. So your lungs don't stick to themselves. Okay? Next time it happens, I'm like, damn you for knocking out my residual volume. All right, dead space. Again, guys, every single breath, that molecule of O2 I just breathed in doesn't make it all the way down to the alveoli just yet. Same as when I breathe out. It doesn't come all the way out and I exhale it. Okay, so that dead space is just gonna be stuff that's kind of stuck in limbo, right? It's kind of stuck in purgatory. That air only made it to the middle part of my trachea. It didn't make it out. It didn't make it all the way down. Maybe it's stuck somewhere in my bronchi, right? It didn't get all the way down to the alveoli. It didn't come all the way out of my mouth when I exhaled. It's just kind of somewhere, but it's not actually contributing to that gas exchange. Okay. Your respiratory rate, what is that?
How many times you breathe in a minute?
How many times you breathe in a minute? This is kind of confusing because are we actually counting your respirations? What are we counting? Your ventilations, right? It's weird. We don't call it a ventilatory rate. We do just call it a respiratory rate, but we're actually counting how many times your chest rises and falls, how many times you breathe in 1 minute is a respiratory rate. Okay. If you take the respiratory rate times the tidal volume, that formula is going to give you your minute volume. What do you think that means? The amount of air you're moving in and out over the course of 1 minute. Okay. Again, guys, I don't care about that in the field. I care about my respiratory rate and I care about my tidal volume when I look and see that chest rise, but that minute volume, it's doesn't really do it for me. I just want to see that respiratory rate be good and the chest rise be good.
Can you explain what the respiratory rate is?
The respiratory rate, how many times a patient breathes over the course of 1 minute.
Trying to think why you'd be interested in that number, and one thing to think of is you do it over time, so you see more than average as opposed
Sure.
to.
Yeah, that's going to be a respiratory therapist thing. You can catch that on like a ventilator setting, but
That would make in our case. Well, not-
no, doesn't matter. All right. So now that I've talked about how all this stuff happens, I usually like to recap everything I've just been talking about with a video. So for people who are visual learners, we're going to watch this video. It's going to show you an animation of exactly how it gets to the trachea, to the alveoli, all that stuff. Okay.
By 2052, respiratory system. To understand the process of breathing, in humans, the main organs responsible for respiration are present in the thoracic cavity. In the thorax region, the rib cage and the dome-shaped fibrous tissue, known as the diaphragm, are observed. Present within the rib cage are the pleural membranes, which enclose the lungs. The right lung is divided into 3 lobes: the right superior, right middle, and the right inferior lobe. The left lung is smaller and has only 2 lobes, the left superior and the left inferior lobe. Both the lungs are associated externally with small tubular bronchi, which unite and extend into the trachea. The trachea has incomplete C-shaped rings of cartilage, which prevent the tracheal wall from collapsing. The trachea leads into the pharynx, which is connected to the nostrils. As we breathe in air, the oxygen molecules enter the nostrils and travel downwards through the pharynx and trachea to finally reach the bronchi. From each bronchus, oxygen travels into the lungs. Within the lungs, the bronchus divides repeatedly to form bronchioles. Oxygen travels through these bronchioles and reaches the alveoli, each of which is surrounded by a network of capillaries. A section of one alveolus shows the presence of numerous alveolar chambers with pores. Blood containing RBCs is seen flowing through the capillaries. The oxygen molecules from the alveolus diffuse into the capillary and then get absorbed by the bluish-purple RBCs. This causes oxygenation of the RBCs, and a transition in their color from bluish-purple to red is observed. The blood moving into the alveolus contains RBCs and carbon dioxide molecules. These molecules are released into the alveolus. The carbon dioxide collects in the alveolar chamber. And then from the alveolus, it travels through the bronchioles into the bronchus, which finally reaches the trachea and is breathed out through the nostrils. So the process of breathing in air rich in oxygen is called inhalation. After the contraction of the muscular diaphragm, the lungs expand and the air rushes in, resulting in the inflation of the alveoli. During exhalation, the diaphragm moves up and the lungs contract. Thus, the alveoli deflate, causing the air to be forced out. This exhaled air is rich in carbon dioxide. This process of inhalation and exhalation is known as respiration, which is approximately 20 times per minute. Summary. In the thorax region, the rib cage and the diaphragm are observed, which play a vital role in respiration. Present within the rib cage are the pleural membranes, which enclose the lungs. The right lung consists of 3 lobes, while the left lung has only 2 lobes. Both the lungs are associated externally with bronchi, which unite and extend into the trachea. As we breathe, the oxygen molecules enter the nostrils and travel downwards through the pharynx and trachea to finally reach the bronchi. From each bronchus, oxygen travels into the lungs. Within the lungs, the bronchus divides repeatedly to form bronchioles. Oxygen travels through these bronchioles and reaches the alveoli, each of which is surrounded by a network of capillaries. As blood flows through the capillaries, the oxygen molecules from the alveolus diffuse into the capillary. This causes oxygenation of the RBCs. The carbon dioxide molecules are released into the alveolus. They are collected in the alveolar chamber, and then from the alveolus, it travels through the bronchioles. Into the bronchus, which finally reaches the trachea and is breathed out through the nostrils.
Crazy.
This disturbing footage was leaked.
All right, so that helped everything come together a little bit better than just my words up here.
Are the lungs like physically separated? Like you can see it if you like open up someone's chest.
I've got a quick question. Can you explain again
Yes.
kind of how the pleura connect the chest?
So there's a pleural lining on the inside of the chest wall. There's also a pleural lining on the outside of the lung. So when they butt up together, those linings stick together and it creates kind of like a suction cup or like a Velcro, however analogy you want to put it. But the pleura, it sticks together, it sticks to itself. And so that way when the chest wall moves, the lung moves with it.
Okay, I got it. Thank you.
Very good-ish. Okay. All right, guys. So normal breathing and normal rates. All right, in an adult, because it varies with kids. In an adult, we have a normal rate of 12 to 20. Anywhere within that range, we consider normal. Guys, I'm not really concerned if I have a respiratory rate of like a 10. If my tidal volume's good and my patient's not altered, I'm not super concerned about that. Moving into single digits, yeah, that's not great. I'm not super concerned if I have a respiratory rate of like a 22, all right? Maybe my patient just got done working out. Maybe they were just involved in an accident and their adrenaline's going, all right? That's okay. But when we go significantly higher or significantly lower than that range, we start to see problems, okay? We want to make sure, guys, every single time, I'll go over this during patient assessment, but when we're assessing somebody's breathing or circulation, I want to know 3 major things: rate, rhythm, and quality. Rate, rhythm, quality. Is it too fast or too slow, or just right? What do I want to know about the rhythm? Is it regular? Can I predict the next time I'm going to feel the heart rate? Can I predict the next time I'm going to see that chest rise and fall? I want to have a regular rhythm. If it's sporadic and it's kind of all over the place, if it's irregular, that's not good. That means something bad. All right, so we want to make sure we have a normal rate, a normal rhythm, and then quality for the aspect of breathing. I'm going to be looking at what? Chest rise. Okay. What do I want to see when it comes to that chest rise that tells me everything's working okay? All right. There's 3 terms I want to see.
Bilateral.
So equal, adequate, and bilateral. I want to make sure I've got both my lungs working. It's adequate to the point where I'm good with that tidal volume, right? And I want it to be equal. I want them to be moving at the same time. Anything outside of that variance means a bad day, probably a pneumothorax. All right, breath down. I'm sorry.
Could you repeat those last 3, please? For
So,
the chest rise quality.
Equal, adequate, and bilateral.
Thank you.
What did you say the normal rate for an adult was?
12 to 20 breaths per minute. All right, guys, breath sounds, we'll go over that in respiratory emergencies. I want them to be clear. I just want to hear the air moving in and out. Anything other than that means different things and they're not good. All right. Again, I want to see those subtle movements of those muscle groups, the neck, the intercostal muscles, the pectoral, and the abdomen. But if I see them used excessively, that means we've got some difficulty breathing, some labored breathing. All right. Muscle retractions, labored breathing, guys. If they're pale, they're blue, they're clammy, they're that what we call diaphoretic, just that little moist on top of the skin. That's telling me that they're not doing what? Anybody know? Starts with a P. So in a sense, yes, getting enough oxygen, but adequately distributing that oxygen to the body. That's a term. So perfusion. Okay, so kind of, yeah, that plays into it. But perfusion, all right? Perfusion means I'm adequately getting enough blood and oxygen to all aspects of my body, particularly my vital organs.
So you're saying that they're cyanotic, cool, damp, that's an indication.
Yeah, that pale, cool, clammy, that triad will typically indicate hypoperfusion, which means I'm not getting A, enough blood to those vital organs, and B, enough oxygen along with that blood. There's a lot of different reasons that perfusion does not occur, but for right now, I just want you to know what that term means. And typically, if we see this pale, cool, clammy, or that blue, we're not perfusing adequately. We got something going on. All right, tripod position. What is this? Medical definition, please.
Not when you have a hands on, you're using your power.
Yeah, so if you see somebody doing this, or if there's somebody sitting down and they are literally propping themselves up, that indicates difficulty breathing, labored breathing. Why? Why did somebody end up in the tripod position?
Because you can't hold yourself up and not get enough oxygen.
Okay, so maybe because we can't hold ourselves up, we're not getting enough oxygen, maybe, but more so something else.
That they need gravity to allow their lungs to fill, like not.
Okay, so that might be part of it, that gravity might help kind of open the lungs up a little more.
I think it shifts.
Structurally, it helps.
Okay, so yeah, the gravity can help, again, open up those lungs a little bit better. What do you think?
Because doesn't your body just kind of naturally want to like crouch over when you can't breathe enough?
So
Like,
again,
it's
guys,
still like this, but
those muscle groups that we use very minutely every time we breathe. Pectoral muscles, neck, intercostal, and abdomen, right? They're only used to being used a little bit. If we have that labored breathing and we're breathing like this for a really long time, what's gonna happen to those muscles? They're gonna get tired. They're not used to being overworked like that, right? So the combination of those muscles being overworked and getting tired out and the ability to try to open up that rib cage a little bit more to get more air in eventually leads to that, what we call tripod position. All right, so we can infer, if we find our patient in the tripod position, A, they're having difficulty breathing, and B, they've been having difficulty breathing for a hot minute, right? Long enough for them to start getting tired.
Professor, I got a question real quick.
Yes, ma'am.
For that tripod position, is that like the same thing as like when somebody just finished with a strenuous activity, or is that something different?
Yeah, so can be, right? And if you just finished like a really intense workout, you might breathe like this because you're trying to catch your breath. Yeah.
Okay, I didn't know if that was the same thing or like, yeah.
Yeah. Okay. Agonal gasps. What is that? Yeah, so it's not really technically a respiration or a ventilation. We will see agonal gasps in patients who are in cardiac arrest. All of those neurons, all of those messages in the brain are firing, and that's just kind of like a last ditch effort for the body to try to breathe in. All right, we call it guppy breathing. And when we watch this video, you'll understand why we call it guppy breathing. Right? Most anybody that is having these agonal respirations or these agonal gasps, they're not going to have a pulse. A pulse. Not really I guess kind of so the last breath, but it's nothing, it's not organized, it's not really doing anything. It's just all those messages misfiring and being like, yeah, everything's gone. It's just that last ditch effort. Okay, so again, watch a couple videos to give you some visual tie-ins. Here is an example of accessory muscle use.
Hi, I'm Kara, and I love making love.
Okay, thank you, Kara. All right, so notice how these muscles are kind of concaving. They're kind of going in. You're really seeing these neck muscles flex. right, so again, the neck muscles, we're really using these guys. We shouldn't see this much movement. Nice, calm and relaxing music, right?
So is this a real event or is this something active?
Okay. All right, so see these intercostal muscles, they're almost like pulling in every time he's breathing because he's working so hard. He's really using his belly to breathe. All right, that's not normal. We shouldn't see that. So again, same thing on this side. So again, neck muscles. Okay, you guys get the idea. I should not be able to see that much movement because I could probably count his respiration from, where that window is, walking the room.
So what was the diagnosis for that?
I have no idea. It's probably maybe like COPD or something related. Yeah. All right. So this is kind of like a real life Baywatch. This is an Australian reality show. It's from years ago. This guy drowned and they pulled him out from the water. Like they witnessed him drowning. He is technically right now, he's in cardiac arrest, which means his heart is not beating. All right. So you'll notice there's no like real organized fashion to it, but he just kind of, his tongue's going to kind of stick out and he's just going to kind of like do the guppy breathing. These are agonal gasps. Yes, ma'am.
Is this from Bondi?
Huh?
Bondi Rescue?
Maybe. I don't know.
I think it's.
Tucker's had 2 shocks. He's in spasm. Tucker's had 2 shocks. He's in spasm.
All right, so now they actually got him back in cardiac arrest, and now he's having that regular rhythm return. Okay, so, yep, we got it back. So you see why we call it like guppy breathing? It's just kind of like, all right. Don't confuse those for actual respirations. Again, if you see those agonal respirations or those agonal gasps, 99.9% guarantee you that patient's not going to have a pulse. We see that during cardiac arrest.
So that's indicative to us that we need to start seeing.
You need to check for a pulse first. But yeah, probably. Okay, everybody with me? We're done with respiratory.
Those.
No. All right. Any lingering questions, comments, concerns about respiratory? All right. Circulatory system, okay? Who does this play hand in hand with? Guys, everything works together, right? We have to have our respiratory system work to get those oxygen molecules on board, to push them into the respiratory or to the circulatory system. What does the circulatory system do? It moves, it circulates the blood to the entire body to give out those oxygen molecules. Okay, so before we hop on here, speaking of those oxygen molecules, when it comes to the red blood cells, okay, think of it as a MARTA bus for those oxygen molecules, okay? How many seats does each red blood cell have on it for those O2 molecules? 4. All right, so it's a MARTA bus with 4 seats for O2 molecules, okay? So then we'll go out, we'll distribute those molecules. Also too, guys, another thing I didn't mention, how do we get CO2? Why do I have CO2 in my body to get rid of via exhalation? Okay, so remember that CO2, it's an acid, right? It's a byproduct of all of these cells doing their job. They have to have energy to do what they're supposed to do, right? Them actually going through and utilizing that energy to perform their function, a byproduct of that is going to be that CO2. It's going to be that waste. All right, so my circulatory system gathers all of the CO2 from every area of my body that is offloading that CO2, and it brings it back around to the circulatory system to get it off loaded via exhalation. Okay, so that CO2 exists because it's a byproduct of my cells doing their job, going through the energy that they need. All right, so circulatory system, guys, we've got two main vessels. What do we have? So, what did you say?
Is it veins and arteries?
Veins and arteries, right? Anytime you see a red tube, that's an artery. What do arteries carry?
Oxygenated blood.
Oxygenated blood, right? And then our other tube we have, that blue tube, is a
Vein.
vein. All right, what do veins carry? Deoxygenated.
Deoxygenated.
Yes. All right. So we have the arteries, we have veins, and then notice arterioles, venules. What does that remind you of? Bronchioles, right? So we start with the main, the bigger bronchi, we branch off to the little guys, and they're the bronchioles. All right, so we have the same thing with arteries. We have big arteries that branch off of our heart and go through our abdominal cavity and kind of branch off to the extremities. But to get to the point where we're supplying blood to like maybe my arm or my fingers, they're smaller, right? So the arterioles are just smaller little thinner arteries, okay? So that's what those are gonna be. And then the venules are gonna be the same thing for veins. They're just gonna be the itty bitty kind of tunneling down to teeny tiny things. That's what those terms are gonna be, all right? We do have two main tubes, arteries and veins. And then we have two main circuits when it comes to the circulatory system. We've got the systemic and the pulmonary. All right, what does the systemic deal with?
The entire body.
My body, right? So providing oxygen via that oxygenated blood through those arteries to my arms, to my legs, to my kidneys, to my toenails, like whatever, you know, not toenails, but whatever needs oxygen via blood, my arteries are going to take that to that blood, to that organ, that tissue, that cell via an artery. Okay.
And Dr. A,
Yes.
don't arteries technically just carry blood away from the heart? Because in the pulmonary circuit, doesn't the pulmonary artery carry deoxygenated
Yes.
blood?
So for the main purpose, we do need to know that for the systemic purpose, arteries do carry away, but they're going to carry oxygenated. It's reversed in the pulmonary system or the pulmonary circuit. So yeah, but yes, you're right. And we're about to get to that.
Okay.
Okay. So we have that to the rest of my body, and then we have its own little pulmonary circuit. Where is that going to be? In my lungs. Okay. These two work hand in hand to make sure I am dispersing that oxygen to the rest of my body, and I'm bringing back that CO2. Because how do I get rid of that CO2? I come back to cross over those capillary membranes to exhale. So these two have to work hand in hand to make sure I'm giving out O2 and I'm getting rid of that CO2. Okay. Hold on. All right, so I've got my circulatory system, right? Who does it directly involve? How do I get that blood to the rest of my body?
With your heart.
It's a pump, right? So the cardiovascular system is directly connected to that circulatory system. I've got to have that pressure from the pumping of my heart to be able to have that blood flow to the rest of my body, to bring it back to my lungs, okay? So, here is my heart, okay? Again, it's gonna be an organ. We do have that specific cardiac muscle that we talked about. What does it specifically do? That's really cool. Yeah, it generates its own electrical impulse. Guys, pretty much we don't have to be walking around plugged into an outlet all day for my heart to work and pump and have that conduction system work, okay? So this is going to be a very large heart. All right, it's not this big. Again, it's about the size of your fist clenched up. We are going to have different aspects when it comes to the anatomy. All right, it's going to be split into two sides. All right, just like we talked about the nose, what do you think this meaty part right here in the middle is that divides it to the right and to the left side?
Septum.
The septum. All right, so the septum of the heart, or the septal aspect of the heart, we're gonna have a right side and a left side, okay? We're gonna have 4 different chambers in our heart. The 2 on the top are gonna be the what? The atria. Okay, so I have my right atria and my left atria. The 2 chambers on the bottom on each side are going to be our ventricle.
Ventricle.
All right, so remember that these are ventricles because they actually come to the point, they form a V shape, right? That looks like a V, V for ventricle, okay? So atria on top, ventricle on the bottom. So I have a right atria, a right ventricle, left atria, left ventricle. Everybody with me so far? Okay. All right, so here we go. Guys, you've got to know the way, the pathway of the blood flow through the heart. This is a little bit intense. You got to know it. It's going to take repetition. It's going to take memorization. But again, we have to know normal before we know abnormal. Because if something's wrong with the heart, we're going to start to see signs and symptoms, and we're going to be like, oh, that's because this part of the heart isn't working. That's why I'm seeing this happening. Okay. So we are going to start, again, anything that is blue is a vein, red is an artery, right? So these big dumping chambers right here, okay, are going to be the superior and the inferior vena cava or vena cava.
What's it? But not part of the actual heart organ. That's like a main.
So it is.
I mean, like a giant blue part.
Right here? The superior and inferior vena cava? Yeah. So these are the main dumping tubes. This is where we're going to start our blood flow. Okay. What do these blue veins represent? What is this carrying?
Deoxygenated blood.
Okay, so the superior vena cava is bringing back all of that deoxygenated blood and all of that CO2 back from what part of the body do you think? The superior part of the body. All right, this is bringing back all of that deoxygenated blood from this half of the body and all the CO2 from this half of the body. The inferior vena cava is bringing it from the inferior, the bottom part of the body. All right, guys. So the superior and inferior vena cava, they are going to dump out into the right atrium.
Right atrium.
Okay, so we're going to dump out right here. These are my superior vena cava. We're going to dump out into the right atrium. All right. Now, guys, we also have some pretty cool aspects to our heart. We have some valves in our hearts because it is very, very important that this blood flow, it happens in the same direction. It goes in one direction every single time the heart pumps. If we start to see backflow of that blood, then we start to have problems. So these valves in our heart, they're one-way valves. All right, so when they close, they do so in a manner that prevents any of that blood from coming back through it and going backwards in the order of this blood flow.
So, okay, so the superior and inferior vena cava take the deoxygenated blood? I'm sorry.
Yes. Yeah, because they're veins, right?
Yeah.
They're going to take all of the deoxygenated blood and all of the CO2 from the inferior and the superior part of the body, and we're going to dump it out into the right atrium.
So that's the
Yes. And then that's going to start the whole process of reoxygenating blood and pumping it to the rest of the body. Okay. All right, so from the right atrium, where are we going to go through? We've got a valve here.
Tricuspid.
The tricuspid valve. Okay, if you look at the model of this heart, you guys can, I guess technically you shouldn't really touch right now, but you can look. It's called the tricuspid because it has three kind of anchoring systems to secure it. They're called 10-day chordae that secure it and anchor it to the ventricle. There's three of them. So tricuspid valve, we're going to move through the tricuspid valve into the right ventricle. Okay. So notice that it's still blue. We're still deoxygenated because where are we going to get that oxygen? Where does it happen? In the lungs. We're going to get the lungs first. All right. So from the right ventricle, we're going to go through another valve called the
bicuspid.
Not yet.
The pulmonary capillary?
The pulmonary or the pulmonic valve, because we're moving into the lungs, right? So up here, you're going to notice the pulmonary valve right here. Now, this is where it gets a little confusing, okay? Because what is our next stop right here? What are these two things?
The pulmonary vein.
So these are my pulmonary arteries. This is where we get that reverse. Typically, we learn that arteries carry oxygenated blood away from the heart. It's opposite for the pulmonary circuit. All right, so it's going to branch off. I'm going to have a right pulmonary artery and a left pulmonary artery. I'm now taking that deoxygenated blood to the lungs to get that magical gas exchange to happen.
Before you move forward, Professor A, I got a quick question because I'm having a little terminology mix up here. Okay, so once we get out of the pulmonary capillaries, is it going to be referred to as the pulmonary vein, or is it pulmonary artery? Because I'm just trying to follow on the chart, and it's kind of confusing because it's kind of like the pulmonary vein and the pulmonary artery are kind of like the same thing.
So they're not the same thing. Just for the definition of an artery, when it comes to the systemic circuit, they carry oxygenated blood away from the heart.
Right.
Veins carry deoxygenated blood towards the heart, right?
Right.
Those are both reversed. So pulmonary arteries carry that deoxygenated blood towards the lungs. Technically, it's still carrying it away from the heart. But once we get that gas exchange and that blood is oxygenated, the pulmonary veins will actually bring that oxygenated blood back to the heart.
Okay.
Yeah, it's stupid why they have to reverse it, but they just did.
Okay.
I know. All right, so we're going through superior inferior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary valve or pulmonic valve into both of my bilateral pulmonary arteries, right? From these pulmonary arteries, I've got to get to these capillary beds so I can get that gas exchange, right? How do you think I get to those microscopic capillary beds? What do I turn into? An arteriole, right? It's still an artery, but it's going to be smaller so we can funnel down to those microscopic capillary membranes, right? So I'm going to go from my pulmonary artery, I'm going to turn into smaller pulmonary arterioles. And then I'm gonna find myself at that capillary bed where I can dump off all that CO2 and say, come on, O2, on board, get on this red blood cell. So once I reach these capillary membranes, I now have an oxygenated red blood cell, right? I'm going to go through the pulmonary venules, right? Because it's kind of like a backward funnel system. I got to be small to get back to the pulmonary veins.
So from the capillary bundles, capillary beds.
Mm-hmm. To the pulmonary venules, to the big pulmonary veins. All right, so I've had the gas exchange, I offloaded that CO2 and I onboarded the O2 molecules here in the capillary beds, right? Pulmonary venules, now I'm in these big pulmonary veins. I've got my oxygenated blood, I'm ready to go disperse it, and I'm going to dump out from the pulmonary veins into my
left atrium.
Left atrium. I know, it's not gonna stick the first time, I promise. All right, from this left atrium, I'm gonna go through another valve. Who is this valve?
Mitral.
So the
bicuspid.
bicuspid valve, again, we have two anchors, also known as the mitral valve, M-I-T-R-A-L valve. They're the same thing. It's easy to remember the valves on the right and left side of the heart because you're going to try before you buy, right? Tricuspid, bicuspid, try something before you buy it. Try before you buy.
So you go from the left atrium to the bicuspid. So the right side and the right lung, 3. And then the left.
Lobes.
Well, yeah, the right side of the heart and the right lung. The 3 lobes, the 3 points.
3 points.
Like the tribe.
So that's just talking about the anchor for, yes. Okay, so yeah, the right lung has 3 lobes and the valve on the right side has 3 anchors. Yeah, okay, there you go. Okay. All right, and then so we are back in the pulmonary veins. We're in the left atrium. We went through the bicuspid valve, okay? And we're going to the right ventricle. Guys, this guy is super important. I'm sorry, the left ventricle is super important because he is solely responsible for what? That pumping action, right? This is kind of the last stop in the heart before we start pumping through those tubes to go give out that oxygenated blood. So how hard or how much resistance this guy has to overcome to pump out that blood to the rest of my body will tell me what my what is going to be. My blood pressure, my systolic blood pressure. The actions of this left ventricle directly reflect what my patient's blood pressure is going to be. Okay. So from this left ventricle, we're going to go through the aortic valve. And now we're going to the aorta. All right, guys, this is the big mamma jamma artery that every single other artery in the body is going to eventually branch off of. So once I go to the aorta, I'm going to go out to the rest of the arteries in my body. They're all over the place, okay? I'm going to be handing out O2 molecules, right? I'll be like, Oprah, you get an O2 molecule, and you get an O2 molecule. Once I have passed out all 4 of those O2 molecules, I'll start collecting those CO2, right? So I'll go from the systemic arteries to the small arterioles. Because guys, everywhere in so many parts and so many points in my body, I have these capillary membranes, these capillary beds. All right, so once I've given out all the oxygen molecules through those capillary beds, I'll go through the arterioles. I'll be in my systemic capillary beds. And then I'll come back through my systemic venules. to my veins, because now I've got that deoxygenated blood. I need to bring it back to the heart and start all over again, right? So from those systemic veins, we eventually turn back into the superior and inferior vena cava, and we start all over. Yes, yes, yes. That I'm going, I try to explain first, and then I do the condensed version, and then you guys watch the video pretty much. All right, so superior and inferior vena cava, we've got that deoxygenated blood, right? We're gonna dump into the right atrium. We're gonna go through the tricuspid valve to make it to that right ventricle. We're gonna go through the pulmonic valve and branch off to both of my pulmonary arteries. I'm gonna go to a pulmonary arterial to make it to those capillary beds in my lung. That's where I'm gonna have that gas exchange. Once I get that oxygenated blood, I'm gonna go through my pulmonary or my pulmonic venules to get back to my pulmonary veins. And then I'm gonna start dumping that oxygenated blood in my left atrium. I'm gonna go through the bicuspid valve to get to my left ventricle. From the left ventricle, I'm gonna go through the aortic valve to my aorta, to my systemic arteries, to my systemic arterioles, to my systemic capillary beds. Now I've done the gas exchange again. And now I'm going to turn into my systemic venules. That will turn into my systemic veins. That will eventually lead back to the superior and inferior vena cava, and we start all over.
Boom.
Boom goes the dynamite. Yeah, guys, I don't expect you to have this memorized by today, okay? But I do expect you at some point, at least by we take the modular test, you've got to have this memorized. I know it's a lot, but again, we have to know normal so we can understand abnormal, okay? Because especially when it comes to heart failure, we will see this blood backing up in different places, and that can tell us, oh, this is left-sided heart failure, or oh, that's right-sided heart failure. Okay, gotta know normal before we know abnormal.
Just, I was looking at this, but there's a lot of good videos on YouTube.
Yes.
That explain this.
Yes.
Layman's term, you just kind of follow along.
Yes.
They're out there, you just gotta find them. I don't remember exactly which ones they were, but there's some really good ones out there.
Yeah, guys, there's a really good subscription, Khan Academy, K-A-H-N Academy is a really good, sometimes they go a little too far in depth for your level, but it's doctors and nurses actually explaining this stuff. They do a really good job with it. And there's a couple more that I subscribe to. I can't remember the name off the top of my head, but yes, YouTube.
Yes, YouTube.
Yes, YouTube. So here's one of them. This is just like showing you a picture and not really explaining why, but just how.
People across America trust Nutrisystem because we deliver your favorite foods made healthier.
Veins are blood vessels containing blood flowing to the heart, while arteries have blood flowing from the heart. The blue is representative of blood vessels containing deoxygenated blood, while the red blood vessels have oxygenated blood fresh from the lungs. Now, let's follow the path of the blood through the heart. The superior vena cava receives blood from the head, neck, upper limbs, and chest. Meanwhile, the inferior vena cava receives blood from the trunk, viscera, and lower limbs. Both the superior and inferior vena cava end up in the right atrium, one of the 4 chambers of the heart. The heart not only has 4 chambers, it also has 4 valves. The purpose of the valves is to keep blood moving in the right direction and not flow backwards. Blood exits the right atrium through the tricuspid valve, so called because it has 3 flaps, and enters the right ventricle. The blood exits the right ventricle through the pulmonary valve and enters the pulmonary artery. Again, it is an artery because blood is flowing away from the heart, but it is blue because it lacks oxygen. The pulmonary artery then splits into the left and right pulmonary arteries, which go to each respective lung. In the lungs, gas exchange occurs. The blood discards carbon dioxide and picks up oxygen. Now, blood comes back from the lungs through the pulmonary veins, entering the left atrium. Next, oxygenated blood leaves the left ventricle through the aortic semilunar valve, entering the aortic arch. The aorta, which is the largest of all the arteries, distributes the oxygenated blood to the rest of the body. The aortic arch has three major branches, which supply the head and arms with blood. Then the aorta curls downward behind the heart, forming the descending aorta, which descends through the chest and continues down through the abdomen. In the abdomen, the descending aorta splits to supply the pelvis and legs with blood.
If you like this video, please like and subscribe. It would help me make more videos. And make sure to comment with any.
So yeah, just repetition, keep going over it, watch the YouTube videos. I don't expect you to know it right now, but you've got to know it moving forward.
Hey, Instructor A.
Hold on. No, go ahead.
Okay, so just to be clear, I'll make the name clear, but like the two on the left side, the two pumps that come from the exterior and the interior.
Superior and inferior vena cava?
Yeah.
Okay.
Like the blood is coming from your anterior and your inferior.
Yes.
Right?
Yes.
And then it goes to your superior. So it's coming from two places, like when you look back out, it's going to your left.
Correct.
Okay, that's all. I'll get the names later, but I was just trying to make sense of that.
Yeah, I think what you're saying is that the blood is coming back from communicate at the top and bottom. Whereas when it's being distributed, it's only going out the aorta.
Right, so we've got the two dumping tubes that bring the deoxygenated blood back, and then we have the main the aorta, that one big aorta that eventually will branch off into the others. But yeah, it comes in two tubes and it leaves in one tube. That makes sense? Yes. It branches off to the rest of the body, but it leaves in the one tube, the aorta.
Well, what is the rest from the top and the bottom? Yeah.
Hang tight after class because I want to figure out exactly what you're asking. Okay. Okay. Everybody need a break? Power through. You tell me. 5 breaks? 5-minute break?
Yeah.
Okay, go for it. All right, so.
Also, your screen needs to be down a little more, Professor. It's kind of up, kind of high.
There we go.
There we go. Thanks.
All right. So with the heart, guys, again, some more definitions. All right. A normal resting heart rate. So we talked about a normal respiratory rate for an adult is going to be anywhere from 60 to 100 beats per minute. Anytime we assess a rate, it's going to be over the course of 60 minutes or 60 seconds. All right, so anywhere from 60 to 100 is going to be considered normal. Technically, if we are 54 heart rate, what is that? Bradycardic, right? If we're at 110, technically that is tachycardic. All right, so same thing that with the bradykypnic and tachykypnic or tachypnic. All right, if it's above or below that normal range, then we're gonna put that med term on it. Okay. Stroke volume, you need to know this. It is the amount of blood moved in one beat of the heart. So one contraction, one pump of the heart, that amount of blood moved is going to be your stroke volume. All right, cardiac output. You take your heart rate, you multiply it by your stroke volume, and that gives you the amount of blood moved in the course of 1 minute. Do I care about that number? Not really. Can I even measure that number, that cardiac output in the field? No. I'm more so going to look at what to understand that my cardiac output is sufficient.
The rate.
My blood pressure, right? If I have a sufficient blood pressure for my patient, then I know my cardiac output is fine, right? I'm not going to have an exact number for what that cardiac output is, but if my blood pressure is good, I know it's good enough. Just like I don't care about tidal volume. I just care about chest rise. right? All right, so again, guys, the heart is an electrical system. Just like that flow of the blood through the heart, it has to go the same direction every time. It has to go the same order every time. Same thing with the electrical system, okay? It has to go the same route every time, all right? So we will talk about very quickly, there is a node that is called the SA node. Anybody know what it stands for? The sinoatrial node. It's in that right atrium. That's going to be what we call the natural pacemaker for the heart. What do you think it does? That's the pace. That's my heart rate. Okay. That sinoatrial node has to be the start line of that conduction every single time for everything to work in tandem. All right.
How do you spell that?
S-I-N-O-A-T-R-I-A-L. Sinoatrial. Right atrium. So that impulse is generated there in the sinoatrial node, and it's going to travel to the AV node. That's the next stop. All right. What does that stand for? Atrioventricular node. Right?
Ventricular.
This is going to kind of be, guys, all of this happens in just like nanoseconds, right? Every single time. We start at the SA node. That's going to be the initial start point. We're going to go to the AV node. And the AV node is kind of responsible for saying, okay, we're going to have a very, very, very brief pause. The rest of the conduction system is everybody in place, everybody ready to go. Okay, let's proceed. So it's kind of like a gatekeeper. He makes the AV node make sure everything is in the right order, everybody's ready to go, and then allows that electricity to proceed through the rest of the heart. Okay, I don't know why the picture's gone. All right, so through the rest of the heart, all right, there's a couple of things called like the bundle of His. We're not going to go into that with you guys. But wrapping around the septum or the septal aspect of the heart and around the points of the ventricles are things called Purkinje fibers. All right, that electrical pulse gets sent through those Purkinje fibers, which causes that contraction, which then causes the heart to continue to be pumped either to the lungs, to the body, wherever it is in that rotation. P-E-R-K-I-N-J-I-E. It's in your book for sure. It might be E-N, but I can't remember. All right, so again, guys, we'll watch the video. It'll explain a lot better than I can because it has pictures. But just know we have the SA node, then the AV node, then the Purkinje fibers. There's the bundle of His, there's some bundle branches that we can see some complications with, but for your scope, we're just going to keep it that simple. It has to go in the same order every single time, or we start to see complications. Okay?
Our first shoe was simple, it was beautiful, it was, as we say, the right amount of nothing.
Or SA node, located in the right. The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the...
We'll talk about that a little bit in cardiology. I'm going to give you guys the tip of the iceberg when it comes to that stuff, because that's paramedic level. But pictures, videos, bring it all together a little bit better. Okay, are you guys just like brain dead right now? Probably.
It's just a lot. That's all it is. It's
I
like,
know. I'm sorry.
yes, it's just.
I go down to the Purkinje fibers.
So it goes to the AV node, it goes through the bundle of His. Technically, it goes to the right and the left bundle branches, and then it goes to the Purkinje fibers. But just to simplify it for you guys, the AV node eventually goes to the Purkinje fibers that wrap around the ventricles that cause the ventricles to contract and pump. Okay. Arteries. What are arteries? What do they carry?
They carry the oxygenated blood.
Perfect. Oxygenated blood, it carries blood away from the heart. So A, artery, A away from the heart, arteries away. All right, so again, guys, that aorta, that big mamma jamma, like that big artery at the very top, every single aorta that's going to supply blood to every aspect of my body will branch off from that. So we have coronary arteries. Where do you think those supply? Heart, right? Because the heart's an organ, right? Guys, the heart actually gets first dibs from that freshly oxygenated blood. It goes to the coronary arteries to make sure that all of the tissue and the muscle and the cells, everything in the heart is getting oxygen. Okay, so it gets that super, super, super oxygenated or super oxygen rich blood. So coronary is going to relate to the heart. All right, carotid. Sorry, question?
Oh no, we're answering you.
Okay. Yes. So carotid arteries, they're going to be bilateral. They're going to branch off of that ascending aorta to go supply blood, that oxygenated blood, to the brain. That is also another pulse point that you're going to check. You're going to feel the carotid artery to see if we have a pulse. Okay. The hepatic arteries. What does that go to? The liver. Okay, it's an organ, it needs blood supply, it has its own artery. Renal arteries, kidneys. All right, mesenteric, kind of your gut, your digestive, your intestines. Okay, so guys, you don't need to know every single layer of an artery. Okay, all I want you to know at your scope is that we do have that muscular component to the arteries. Remember, what kind of muscle is it? Smooth muscle. I can't control it. It's involuntary. All right. So that smooth muscle inside my artery is how my brain can regulate my blood pressure through those hormones. It can tell that artery to contract or, release to control my blood pressure. Okay. All right, we talked about that. Okay, so a pulse. What's a pulse? What are we feeling? We already said we're touching what to feel a pulse? You're touching an artery. Like you're literally touching right here underneath the skin, obviously. You're feeling that radial artery. You're feeling that carotid artery. All right, you have another really big pulse point right here in your groin called your femoral artery. But where are your femoral pulse point? We're literally touching and palpating that artery to feel what?
A pulse.
Oh,
Bump, bump, bump. What is that bump? What am I actually feeling?
Pumping of the blood.
Okay, so yeah, combination, right? I am actually feeling the blood rushing up, hitting up against that arterial wall. So I'm feeling the blood moving through the artery when I palpate a pulse. Depending on how hard my left ventricle has to work to overcome any kind of resistance to make sure the rest of my body is perfused, right, gets that oxygenated blood, is how strongly I'm going to feel that bump, right? If I have a nice, strong pulse and I can feel that bump, all right, my blood pressure is probably nice and right where it should be. If you palpate that artery and you feel it's just going bam, 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 it is forcefully, you're feeling that very, very forcefully, what can you infer maybe about your blood pressure?
It's probably a little high.
It's high. Same aspect, if I feel a pulse point and I can barely feel it, what can I infer about my blood pressure?
It's low.
Probably low. Guys, we have magic numbers that we'll talk about for these different pulse points, but you can tell a lot about your patient's status, that initial status, just by checking a pulse. We can tell how fast, all right, or how slow it is. We can get a little bit of gauge about what their blood pressure is, and we can feel if it's what? Because what are the three things we want to know? Rate, rhythm, and quality. So rate, too fast, too slow. Rhythm, can I predict when it's gonna beat next? Or is it skipping some beats and then we pause for a minute, or is an irregular heartbeat? And then the quality we're referring to is how strongly you feel that pulse hitting back at you, right? Is it nice and strong? Is it what we call thready, like needle and thread? That means that it's weak. Or is it what we call bounding? If it's really punching at you, that's going to be super, super strong. It's bounding. That means my blood pressure is probably high. Okay. All right, so guys, here, this is in your book. You do need to be familiar with these arterial positions. All right, there's only a couple we utilize to assess a pulse, but you need to know that every organ, every major part of the body does have a blood supply via an artery, okay? So we talked about right here, bilaterally, we have the carotid artery. All right, we have one here that's called the subclavian artery. That'll come into play for a couple things later on down the road. We have right here, a big one that runs along the humerus. What is that called? Anybody know? The brachial artery. And then it's going to come down to the bend in your elbow in what we call bifurcate. So remember, we've said that before, it kind of splits into two. And then we have the radial artery. That's where we palpate that radius, or that radial pulse. It's up against the radius bone. And then the ulnar artery that hits up against that ulnar. All right. We have, again, the ascending aorta and the descending aorta. It goes up and it wraps around the back of the heart. All right, so that descending aorta starts to go through your belly. Then we have that renal artery, that hepatic artery that branches off to go supply to your kidneys, your liver. That descending aorta comes to the pelvis. It bifurcates, all right? So we have that really big femoral artery go down each leg, and then again we bifurcate again at the knee, and we branch off to a tibial pulse and a fibular pulse. You also have some major arteries behind your kneecap or behind your knee. They're called the popliteal arteries. All right. So those are the big major ones you need to know. This becomes a lot more important when you go to AEMT, because when you start IVs, where do they go? In veins or arteries?
They usually go to the brachial artery.
In veins. We put IVs in veins.
Excuse me, vein, sorry.
Because we're pushing that fluid and that blood back to the heart to circulate to the rest of the body. What happens if you put a needle in an artery?
Bad things, that's why I said my bad.
You're going to make your patient bleed out. All right, that circulatory system, we like for it to remain closed. If we sever or have an opening into an artery, that's where we can lose blood and we can bleed out and we can die. So you'll go over this extensively in AEMT, especially where all of these veins are located, but know that you got to know that a little bit more in depth for A. Okay. If you guys are just saying, okay, so I'm just continuing to end. All right, everybody good with what capillaries are? All right, those are the net mesh looking things that surround the alveoli. It surrounds the different areas of the body where we get that gas exchange for O2 and CO2, right? Okay, okay. So again, guys, veins, they bring back that deoxygenated red blood cell. All of those CO2 molecules is picked up on the way. We dump it where? Into the right atrium, so we can start that process of getting rid of the CO2 and getting more O2 on board. Okay. All right. Guys, those are the heavy hitters. Okay. Respiratory, cardiovascular, circulatory. I know it's a lot, but is everybody okay-ish with the big three? All right, so the spleen, what does the spleen do? Anybody know?
It's like a filter for your blood cells, so to speak. Clears out any kind of like foreign objects or things like that. Not objects, but substances in your blood.
Okay, so kind of, sort of, yeah. All right.
It makes bile.
The what?
Doesn't it make bile?
No.
No.
No, that's the gallbladder.
Spleen, first off, where is it located?
It's kind of close to your stomach.
Left upper quadrant. That is where your spleen is, and is in your left upper quadrant. Guys, your spleen is kind of like the elephant graveyard for your red blood cells. Kind of where they go when they've reached the end of their lifespan, they go to the spleen, they get dissolved, and that's where they go to die, pretty much. Okay, the spleen is very vascular. It's got kind of a reservoir of blood, kind of for a rainy day too. So if we ever see any signs of bleeding in that left upper quadrant, we are very concerned that the spleen has been compromised and my patient can bleed out. We'll get to that during patient assessment, but no, it's very vascular and it's very prone to being injured and having internal bleeding. Okay. So again, it filters the blood. Left upper quadrant, it's the elephant graveyard for red blood cells.
How is that similar to different things?
They kind of all do kind of the same thing. The spleen doesn't really create any waste as much as the kidneys do, but they're all pretty much filtration systems. Yeah.
Where does the blood cells go?
They kind of dissolve and they're reabsorbed. Yeah, recycle. Self-sustainable. All right, leading into blood. All right, so we have different things that compose my blood. All right, so we're going to talk about blood stew, right? Like vegetable stew or beef stew. You got different ingredients, but it all ends up in the same pot, right? All right, so my red blood cells or my erythrocytes, we'll call those the potatoes in my blood stew. What do? They're smartabuses, right? They carry my O2 and then they get that CO2 back and they are very vital in that gas exchange, right?
They carry 4 oxygens. Is it similar CO2? Is it 1-to-1?
I would have to confirm that. I can't give you an exact answer, but it's probably in the same ball field.
I think it's 4 oxygens per.
Technically, it is hemoglobin, yes.
I think this comes hemoglobin per.
Yes.
There's a lot of hemoglobin per blood cell.
So, but simplifying it for you guys. Yeah. White blood cells, my leukocytes. Let's call those the carrots in my blood stew. All right. What do?
They help with the immune system.
So they help with my immune system, right? If I have any foreign invaders in my body, bacteria, virus, anything like that that shouldn't be in there, they're the ones who say, all right, let's rally the troops. Let's go find this bacteria. Let's go find this virus. Let's kill it off so it doesn't kill my body. All right, so they deal directly with infection control. All right, my platelets, we can call those the onions of my blood stew. What do?
They help you clot.
Okay, so they help you clot. Right? They're very sticky and they kind of have like a Velcro looking appearance. So when we cut ourselves, whenever, okay, so you have a minor cut, you're cutting up an avocado or something, I don't know. You get a small cut, unless you have like hemophilia or something like that, do you die from that little cut? No, what happens?
You start to clot.
All right, so my brain recognizes, ow, my sensory nerves. I perceive pain here. I have an injury. Let's send increased blood flow to that injury site so we can heal myself from the inside out. Right? Those platelets start to join together and they start to form a clot, and eventually the bleeding's going to stop, right? And you'll eventually form a scab. That scab will fall off and your skin will be back good as new. All right, so those platelets, excuse me, are a major component into that clotting factor, being able to stop that blood from escaping. And then also, they can be bad as well, but we'll talk about that later. All right, so my broth that all of my components of my blood are floating around in is what? Plasma. Okay, so plasma is like a clearish, yellowish liquid that kind of keeps everything all together. All right, anyone who has tattoos or has like ever had like a very superficial scratch or like road rash, if you've ever seen that kind of stuff just like oozing out of it, like that yellow stuff, that's plasma. All right, it's very important to make sure that we can lose fluid via plasma. All right, we need to make sure that that helps stay together. We have enough in our body to make sure that our fluid levels are appropriate.
What was in blisters?
Yes. Yes, if you ever have a blister and you pop it and that like yellowy stuff just kind of leaks out, that's plasma. Lovely, right? Everybody good with blood stew?
Why we got blood stew?
All right, so guys, let's talk about blood pressure really quickly. Okay, so we've already talked about who's directly responsible for my blood pressure.
It's your heart.
The left ventricle, right? That left ventricle is the last stop for that oxygenated blood before it is forced out to the rest of my body through those arteries. All right. So depending on the status, how clean my arteries are, is going to depend on how hard my left ventricle has to pump to overcome any kind of obstacles inside of my arteries. All right. What kind of obstacles do you think can be inside my arteries?
I forget the formal term for it, but like fat cells or fat, what is it? I forget what it's called.
I don't know if you guys can see this over here. Sorry if you can't. All right, so let's say this is my artery, right? Nice, clean, smooth artery. I can have two main things that can develop what we call vascular systemic resistance. Okay, vascular systemic resistance. This means that there is something inside my vascular system that is creating an obstacle, if you will, for that blood to have to go around. All right, so we have two things that can cause it. All right, we talked about that. Those platelets, they're good if when they stick together, we don't want to bleed out, right? But we can have that nasty through really bad diet, really bad genes, sedentary lifestyle. We can have like that plaque.
That's what I was trying to say.
That nasty stuff, right? If you ever go to the dentist and they scrape that stuff off your teeth, they scrape the plaque off your teeth, that's the same thing. It's in your arteries, inside your arteries, all right? So we can have one little piece of plaque right here, okay? If we're not changing our diet, if we're not modifying our exercise routine, right? All of this plaque, it'll start to stick to itself. So it'll stick to itself, and it'll start accumulating, and it'll form one big kind of glob right here, all right? So instead of free flowing normally in this nice, smooth, open artery, my left ventricle is now gonna have to pump even harder to go around that plaque obstacle to get to the rest of my body and to effectively perfuse. And guys, I think I had a dyslexic moment. I think it's SVR, it's systemic vascular resistance. So swap that there. All right, if we have this plaque and it's causing that SVR, that systemic vascular resistance, that's going to be called atherosclerosis. A-T-H-E-R-O-S-C. Oh God. L-E-R-O-S-I-S. It's in here on a slide, I promise.
Can you repeat the word?
Atherosclerosis. If it is plaque that is causing that resistance, is atherosclerosis. We also have a condition called arteriosclerosis. These get commonly confused, and now you can see why. Athero and arteriosclerosis. That arteriosclerosis typically comes with older age. All right, those muscles inside of the arteries, they get kind of hardened. They're not as flexible. They're not as pliable. So they're not able to expand and contract normally, like normal healthy arteries will. So again, it forms resistance that left ventricle has to pump even harder to get around or to get through to make sure that the entirety of my body is being perfused. All right. So that's going to come into play when we talk about the systole or the systolic number when it comes to your blood pressure. Because when you see blood pressure written, guys, it's going to look like some type of a fraction. All right, you're either going to see it written out like that, or you're going to see it written out like that. Okay, that top number, the larger number, the bigger number, that's going to be your systolic number. That's directly measuring the amount of force that left ventricle is having to use to contract to overcome that systemic vascular resistance. The more resistance in the arteries that we have, the higher that number's gonna be. Textbook perfect blood pressure is 120/80. A systolic measure of 120, a diastolic number of 8. Again, if you just have a really bad diet, you're diagnosed with hypertension or high blood pressure, then that top number can be up to 200, over 200. That's just saying your left ventricle is having to, every ounce of energy it has, every single time it pumps, it's having to work that hard because your arteries are in that bad of a shape. Okay? So again, that systolic is going to be the sheer force that left ventricle has to use to overcome that resistance. All right. So in a very small framed person or in like an athlete who's very conditioned, that systolic number could be like, around 100, under 100, because they're a well-oiled machine, they have a great diet, and everything's in good shape. Okay. Everybody good with what the systolic number means?
Yes, ma'am, but I have a question about the diastolic though, since you brought up like the number being higher. Is there such a thing as that diastolic pressure being too high? Like, has there ever been an instance where it's too high?
Oh yeah. Typically we'll see that both numbers are going to be way too high, right? So the diastolic number means that you're allowing a period of relaxation for all of those ventricles to refill, all of those chambers to refill. It's a moment of, we still have like volume in a sense, but we're allowing a moment of rest to allow those chambers to refill with blood so we can pump it back out. So yes, if it's too high, that diastolic number is too high, it's telling me that my heart's not having enough time to rest and fully function.
Okay, so basically,
a high diastolic number can mean that your heart's being overexerted.
So, okay, so basically they kind of work hand in hand. If there's something on the diastolic side wrong, there's usually something going on with the systolic side.
Yes. There are different ways. Yeah, there are different ways where the numbers can go like towards each other and away from each other, but we'll get into that a little bit later on. But yeah, they typically move in tandem. If one goes up, the other usually goes up. If one goes down, the other usually goes down. Okay. Everybody okay-ish with systolic and diastolic, what they mean and what normal numbers are?
So like what exactly does the diastolic measure? It's just like a time.
So just if we have enough time for the hearts and the chambers to relax and refill and kind of like have that moment of rest, if you will.
So like if the diastolic pressure is lower, then that means it has more time?
Correct. Yes. Don't worry about that. I'll talk to you guys about how to get that blood pressure when we get into patient assessment. Okay. So going on blood pressure and these pulse points, right? If I assess a radial pulse in somebody and I have a nice, strong thump, 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 there's a magic number that I can assume my systolic is at least at this number. Anybody know what the magic number for the radial pulse is? 90. If I have a strong radial pulse, I can assume that my systolic reading is at least 90. Okay, guys, that 90 mark is what we really strive to be the bare minimum to assure that we are properly perfusing the entire body. All my vital organs, all my extremities, it's enough pressure to get that oxygen to where it needs to go. That 90 is a nice, solid number.
Is that because the person's under stress or something? Or is that normal?
So this is the systolic, the bigger number.
Oh, I'm sorry.
Yeah.
Radio.
Okay. So what happens if I feel for radial and it's not there? I can infer my systolic is under what number? 90. There's another magic number for the carotid. Okay, if I can palpate or feel a strong carotid pulse, that means my systolic is at least a what?
60, I think.
60. So if I have absent radials, but a strong carotid, I know my systolic is somewhere between 60 and 90. Is that great? No. Right? When we start dipping below that 100 mark for the systolic, remember again, that 90 is about the bare minimum we can have to make sure it's perfusing adequately, depending on the size and health of the patient. But yeah, I need at least 60 to make sure my brain is being perfused. If I have an absent carotid pulse, guess what that means? You're starting CPR. We're not perfusing. Okay? That tells me my heart's not beating and I'm definitely not having any kind of blood pressure to perfuse even my vital organs. All right, so 60 for radial, 60 for carotid, 90 for radial. All right, so guys, we've already talked about perfusion. That's the definition to make sure the heart's working like it should be. we have a good blood pressure, and we have that oxygen on board, and my heart is pumping through my arteries to every aspect of my body, down to my pinky toes, to my brain, to my heart, all of that good stuff. Everybody is getting the right amount of blood pressure and the right amount of oxygen. That's what perfusion means. Okay, so again, if we see that pale, cool, clammy presentation of our patient, we can infer hypoperfusion. We're not getting as much pressure and as much oxygen as we need. That's also called shock. They're going into shock. They're not perfusing adequately. They're hypoperfusing. We'll talk about that later. All right, so the nervous system, okay? Guys, this is gonna go talk about how we have that involuntary response through our body, okay? So really quickly, sympathetic nervous system. What does this deal with? Fight or flight, right? This is when, all right, you're home alone, right? You know nobody's supposed to be in the house. That would be great. No husband, no kids. Or at least one night, please. All right. So you're home alone. Nobody's supposed to be there. Nobody's supposed to be coming by. It's just you and your beagle, Charlie, right? You decide you're going to go take a shower. You get in the shower. What are you in the shower? You're naked, right? You're vulnerable. You're prone, you're vulnerable to attack in the shower, right? All of a sudden, you're in the shower by yourself and you hear a really loud thud. Immediately, guys, within seconds, what is happening in your brain? What do you perceive that sound as?
There's a burglar in my house.
Right. There's not supposed to be anybody in here. Somebody's breaking in my house. Somebody's going to come in here and kill me. Oh, crap. All right. I'm perceiving through that sound and the rest of my environment that that's going to be a threat. That's a source of stress. All right. Again, guys, within seconds, nanoseconds, all of this is happening. The brain's perceiving it's a threat, and my brain's going to say what? Yo, we either got to get ready to fight for your life or get the heck out of Dodge and run really, really fast. Because my brain ultimately always wants to preserve what? My life. It's going to do anything possible to preserve my life, to save my life, right? So the brain realizes this, and it sends a message to an endocrine gland called the adrenal gland. We'll get into it a little bit later. And it tells my adrenal glands, hey, you're responsible for the hormone epinephrine or adrenaline. Code red alert, this is a threat. I need you to release epinephrine into the bloodstream. Okay, that epinephrine that gets released from that adrenal gland into your bloodstream causes a physical reaction. Okay, what happens? So your sympathetic nervous system kicks in. You're getting ready to fight, right? You get that adrenaline rush.
Uh-oh.
Instructor A, the audio dropped. We can't hear you.
We can't hear you.
Muscles. They tense up. Okay, all of this happens within seconds. All of that messaging has been relayed. We perceived a threat. My brain says, hey, this is not good. Adrenal glands release adrenaline. It dumps into your bloodstream, and then all of these physical things start happening. Okay. How does my blood pressure go up? How does that happen?
Your left ventricle starts to pump. Your heart starts to beat a little faster.
So my heart's beating faster. That has something to deal with it. But what were you going to say?
And then the muscles in your arteries contract and tighten.
Right. So my brain, that adrenaline, that epinephrine coursing through my veins tells that muscular component of my artery to constrict. It's called vasoconstriction. All right, so guys, imagine your artery as a water hose, a garden hose. It doesn't have the spray attachment on it. It's just a free-flowing garden hose. Okay? If you have it normally free-flowing, that's going to be your normal resting blood pressure. If your brain tells that muscle to constrict and to contract, that is like taking your thumb and putting it halfway over the opening of the garden hose. It makes the diameter smaller. So how does that water flow out when you constrict half of that diameter? It comes out with higher pressure, right? That's what happens with vasoconstriction. Your vessels squeeze up, they become smaller, and that pressure going through that smaller hole intensifies. So that's how your blood pressure increases, through vasoconstriction. All right. Are we worried about digesting food when it comes to fighting for our life? No. So our body does a really cool thing called shunting. It says, hey, gut and digestive system, I don't really care about you right now. I'm going to take all that blood that I'm supplying to you, and I'm going to push it towards my vital organs, my brain, my heart, my lungs, because I got to get ready to fight for my life. Right? So all of that happens, guys, within split seconds. It's freaking nuts. Do you have to think about it? No, it just happens. Can you control it to a certain extent? No. All right? So then what happens? You get out of the shower, you go, like look around the house, all right? And then I find it's my stupid beagle. Charlie jumped up on top of something. He made something fall over. I realize that I'm no longer, under attack, if you will. My brain says, okay, we don't have to fight for our lives. Once that adrenaline rush starts to calm down, what starts to happen? Everything goes back to normal. Your heart rate slows down. You vasodilate, which means those muscles aren't constricted anymore. They relax. You remove the thumb from your garden hose of your arteries, and your pressure comes down. Your pupils constrict. They get smaller. Your muscles relax. And then you have the blood flow return back to your digestive system. Okay? So we have the fight or flight. That's the sympathetic nervous system that kicks everything in with that adrenaline. All right? And then the parasympathetic nervous system starts to pull everything down. You might hear this referred to as the rest and digest, or the feed and breathe, because all of the blood flow starts to return back to your gut. All right? Because we're no longer concerned about fighting for my life or running away. It's not a threat. It's my stupid dog. I can calm down and go back to the shower. Right? Okay. Are we okay? Mm-hmm. All right, so again, guys, your central nervous system, this is going to be the absolute vital functions, all right? This is going to include your brain. Is your brain vital? Yes. All right, so your brain has three major components that we're gonna go into for this course, all right? We've got this big chunk right here is the cerebrum, this little pizza pie looking thing called the cerebellum, and then this itty bitty guy right here. That's your brainstem. What does your brainstem control? All of your vital functions, right? Everything. So that little guy controls your entire life. Crazy, right? So again, we've already talked about the spinal cord. It's directly connected to the brain. We've got our vertebral highway. We've got the exit ramps for all of these nerves to go out to the rest of the body to do their thing, right? Guys, we have sensory nerves. We have motor nerves, all right? Each of them have different responsibilities. All right, determining the difference between pain and pleasure, hot, cold, pressure, soft touch. All right, those are those sensory nerves, and those motor nerves are responsible for reacting to those sensations. Okay, so immediately, guys, if you walk up to a hot stove and you put your hand on it and it's really, really hot, what is a knee-jerk reaction? Ow. Again, within those nanoseconds, the brain Those sensory nerves are telling the brain, hey, ow, 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 this hurts, it's too hot. The brain says, well, wait, if it's too hot, that could be a threat to my life. The brain turns around and says, this is a threat, we need to fix it. It sends a message to those motor nerves that control my muscles, and says, remove it immediately so we don't get burned. Do we have to think that through? Happens like that. That's why it's so important that those exit ramps are open so we can have that communication and the follow through from those orders the brain is giving happening, right? All right, so guys, we've got this somatic nervous system. That's going to deal with the voluntary stuff, okay, the things I can't control. I do want to remove my hand type thing. The autonomic nervous system, again, that's going to branch off into that sympathetic and parasympathetic, that involuntary stuff I can't control. Okay. So again, we've got sensory nerves and motor nerves. They relay different information. They're responsible for different kind of actions and reactions. Does this hurt? Yes, it does. Let's remove that body part from that pain, right? Everybody good? Ish? Okay. All right, so skin, guys, the integumentary system, guys, your skin is the biggest organ of the body, right? In itself, it's an entirety, it's an organ. We have two main layers. We have our epidermis. So again, the epi means on top. And then we have our dermis. So that epidermis is going to be everything that you can see with the naked eye, right? That dermis is going to go into a little bit deeper level. So here's kind of a cross section of our skin. Okay, we have the epidermis here. Notice that we've got these red and these blue tubes, right? We have arteries and veins. We have vascular supply to every aspect of our body, including our skin. So when we start to get to the very top of that vascular level, that's going to be the epidermis. And then from that point down, up until the point where we start to see what? What is this yellow stuff?
Fat.
Adipose tissue. All right. That layer is going to be the dermis. All right, so that deeper layer, you notice we have our hair follicles, we have these sweat glands, because why do we sweat?
Down.
Okay, thermoregulation. If we get too hot, we have this moist substance cover our skin. All right, what happens when our skin becomes wet?
We release
right?
heat.
You what?
We release heat.
Right. Okay. So a moist surface, anytime air passes by a moist surface, it will cool it down quicker. Okay. So that's why we have the sweat glands to thermoregulate. Also, why do we have this thing right here? It's called the erector pillae muscle. What does this have to do with? Goosebumps. On the other side of thermoregulation, if you're really, really cold, all right, you get what? Goosebumps. What happens to the hairs on your arm? They stand up. All right, when you're cold, that erector pillae muscle constricts and the hairs on your arm stand up, and all of those hundreds of thousands of millions of hairs next to each other traps heat, and it keeps to the surface of your skin to make you warm. Okay. What also happens if you get really cold? Can't control it.
Start to shiver.
Shiver.
Why do you shiver? What's happening?
Your body's trying to warm itself up.
Friction, right? We're causing those muscles to contract and to tense. A byproduct of movement is heat. So between goosebumps and shivering, that's the body's way of trying to make sure our core body temperature doesn't go too low. Kind of cool, huh? All right, so guys, again, we get down to the deeper layer. We start to see the adipose tissue or fat. And then this area from the fat to where we meet the muscle, because this right here is muscle, that's going to be the subcutaneous tissue. All right. Notice this fascia layer right here. What is this? So that kind of, it cases, if you will, your muscles and allows that connection between your muscles and your skin. It's kind of like a sausage casing for like link sausage.
I was gonna say glue.
So glue, yeah. But literally it does look like that kind of silvery film, like when you eat ribs, the fascia. If you eat ribs, that silvery kind of film that you can pull off the back of them, that's fascia. Okay, we'll talk about that when we get to trauma. That'll come into play, but just know what that is and that it's there. All right, so we talked about thermoregulation transmits information from the environment to the brain, because what do we have in our skin? Nerves, right? Those sensory nerves. So again, I touched something, it's hot. Those sensory nerves are going to tell my brain. My brain's going to tell my muscle to say, hey, move away from that hot source. All right, how does it help protect my body from the environment?
Because like if you get like hurt or something, and it's just like a surface level thing, your skin just kind of takes the hit and it's better your muscles.
Okay, so yeah, but guys, it serves as a major what? Barrier between all of the germs and the cooties and the bacteria and the viruses in the outside world from the inside of my body. All right, because I don't want a lot of that in here. It's not supposed to be in here. So that's why when we have like a significantly open wounds, we've broken that barrier. It's very susceptible to infection, because now it's just saying, yeah, germs, bacteria, virus, come on in, get in my bloodstream, make my whole body sick, right? We don't want that, okay? How do we have that thermoregulation? What does that sweat come out of? Your pores. Your pores. So remember that we can't have, if stuff can come outside from the pores, it can also go inside. So we can have either intentional or unintentional exposure with through the pores, right? Anybody ever use like the steroid cream or like Benadryl cream or any type of topical cream? That's how it works, right? Deep through your pores, gets in your bloodstream, it does its thing. So we can have intentional or unintentional chemical or drug exposure through the pores as well. All right, so digestion, guys, you gotta know this stuff. You gotta know where everything is in your abdominal quadrant. Okay, so my right upper quadrant, who all lives here? My liver, that's the big organ in my right upper quadrant. What does my liver do? Okay, so it filters, right? Any kind of toxins or stuff that doesn't really need to be in my body, that's the first line of filtration, is my liver. All right, so technically, you need to be apologizing to your liver when you go on a bender drinking weekend. Because to our body, alcohol is a poison. It's a toxin. That's why you see these people who are alcoholics, they drink day in and day out, they eventually develop what?
Cirrhosis.
Cirrhosis of the liver, liver failure, because they are constantly overworking their liver to filter out this poison that we're putting in our body. Okay, it's working too hard, it eventually taps out, and it's like, dude, I can't do this anymore. Turns into liver failure. That's not good. All right, so what else is in my right upper quadrant?
The gallbladder.
My gallbladder, what does my gallbladder do?
It's a bile conductor, or it probably helps you process bile in your system.
Okay, so it stores, it creates bile. What is bile? So
Bile is
it is an
chemical that breaks
enzyme that
down
is
food.
released when we ingest like those really fatty or oily, those stubborn foods that we eat. That bile is released to help kind of go and break down that material, that fat, so we can digest it a little bit better. Okay, can you live without a gallbladder?
Yes, you can.
Yeah, you can. We'll
Just
talk
can't
about
have a bunch of
problems when
greasy
it comes. Sorry?
They just can't do a bunch of fried and greasy foods once it's
Right.
gone.
Change your diet for sure. But you can live without your gallbladder. Okay, we'll talk about gallstones and all that stuff a little bit later. But Your liver and your gallbladder are the main key players in your right upper quadrant. All right. There's one organ that lives, or in between your right upper and your left upper. It's not in this picture, and I don't know why it's not in this picture. Your pancreas. What's your pancreas responsible for? Insulin. We will get all into the shugs later, right? But just know it releases a certain hormone that is directly responsible for regulating your blood sugar. So it's in between the right upper and the left upper. Right about here. All right, what's in my left upper? We already talked about one thing.
The
elephant graveyard. The spleen. All right, so that's my left upper. Also, my stomach is in my left upper quadrant. What does that do? Helps digest. All right.
And you get all your nutrients.
Liquids and those solids that I go through my esophagus into my stomach, and then it starts to digest. It starts to break down that stuff so I can send it down further, the intestinal tract, and get everything that I need from that food. All right. Right lower quadrant. What's down here?
That's going to be part of your
appendix. Let's talk about this guy for a minute. What does your appendix do? It helps what? So, kind of yes. They don't really have 100%, hey, this is exactly what the appendix does. All we know for certain is it's a toxin reservoir. All right, additional toxins, nasty, ooey bacteria will go and hang out in the appendix. Okay. Who has ever heard of a ruptured or inflamed appendix? Right, who's had that happen? Anybody? Yeah? All right, we'll talk to you later. But
I had one.
be very conscious and very aware that can become irritated, it can become swollen, and it can rupture. Do we want toxins in our bloodstream?
Nope.
No. So be aware of the appendix that's in your right lower quadrant. We'll talk about that a little bit later, but that's where it is. That's what it does. What else is in your right lower quadrant? Intestines. Okay, what do they do?
And move that crap through your system to your rectum.
Literally, they move crap through your body. Okay. So guys, all I want you to know about the intestines when it comes to this class, I want you to know big, large, and I want you to know small. Okay, we'll get to that in just a minute. What else? If I'm a female, what's in my right lower quadrant?
Ovary.
Okay, so reproductive organ for female. What's in my left lower quadrant? Other ovary, if you have to. All right, and intestines. Right. We talked about, guys, your bladder sits right here, kind of in between your right and your left lower quadrant, and it's protected by your pelvis. Okay, so those are the major key players that you need to know.
Where are your kidneys at?
Oh, so thank you. Your kidneys are not technically in your abdominal quadrant or your abdominal cavity. They have their own little space. Where are they?
They're like closer towards your back.
All right, so they're here-ish, right? They have their own space called the retroperitoneal space or cavity. Retroperitoneal. That is the home of your kidneys. They are technically not in your abdominal cavity. What do your kidneys do?
They flush out toxins.
Okay, so it's another filtration system. All of the excess levels of stuff that we don't want in our body, toxins, sugars, fluids, electrolytes, all that stuff. Remember, we want to try to keep that homeostasis level.
Yeah, whatever you don't need.
Right. We will go, all of that stuff will go to the kidneys. The kidneys will filter it out, and it creates what?
Urine.
Waste. It gets rid of the waste via urine. Right? So when we're peeing out excess fluid. We don't need excess sugar, extra toxins. All of that stuff is coming out of our body through urine. It's going to be an awkward conversation, but that's going to be part of your interview with your patient. Hey, let's talk about your pee. What color is it? What does it smell like? What does it look like? It can tell us a lot. Okay. Blah, blah, blah. Talked about that. All right, so guys, lymphatic system, the spleen is included in the lymphatic system. It's more, it's like a filtration system. It deals with like infection control. So just know, especially guys, if you're sick, right? You go to the doctor and they feel right here, these little lymph nodes. They're usually inflamed and they're a little bit painful because they're trying to get rid, they're trying to filter out that infection, whatever's going on, through the glands and all of that other stuff. We don't really go too much into that until a little bit later. All right, guys, you have different glands throughout your body. Okay, the pancreas is one. We already talked about that. The little top hats that sit on top of your kidneys, those are your adrenal glands. Those control your adrenaline. Okay, your ovaries, your testicles, those are your reproductive glands that control your reproductive hormones. Your thyroid up here is a big one. It controls like your metabolism, how fast you can process and digest food. And then we have the thymus gland. It's right here. It's a lot larger in kids. It has a lot bigger role in children. It starts to really help develop and boost their immune system. And we don't really use it when we become an adult. It gets smaller, it just kind of sits there. Doesn't really do much. All right, so that's typically we see that a bigger deal or a bigger player in pediatric patients. We'll talk about these later in the brain. So again, guys, our kidneys, we're in the retroperitoneal space. We get all of these toxins, these extra fluid levels, they go through the filtration system of the kidney. It creates, we get rid of that waste via urine. And we transport that urine that we make in the kidneys through this little tube called a ureter. We have kidneys bilaterally, most of the time. You can live without one of your kidneys. And we have bilateral ureters. Okay, the urine drains into your bladder. And then the exit tube for that urine is going to be your urethra. Okay, males and females, we both have urethra. In males, it is contained inside of the penis. So it does have that external factor versus internal when it comes to females. We'll talk about the differences in that momentarily or later. I can't remember in this chapter. Okay. All right, male genitalia. What is one of the major differences in male genitalia versus female? Okay, so males is all external, right? The penis, the testicles, all of that stuff is all outside of the body. It's contained, right? But it's outside of the body. When it comes to reproductive organs for females, everything is internal, all right? With males, that means that they are more susceptible to what being external? Injury, trauma, right? All right, I'm not gonna go too far into this because there's a specific chapter talking about the fun bits. So here's the female reproductive system. So again, we can live without one or both ovaries, right? There's one on each side. Each month, once we reach maturity, we start to shed an egg through the fallopian tubes. It makes its way down through the uterus to the cervix, out the vaginal cavity. That's what we are, we refer to as a monthly cycle or a monthly period. We'll talk about what happens when we make babies and things change. But again, this is a cross view here. All of it is internal, okay? When it comes to urethra, what is a big difference between male and female with that? So again, external and internal, yeah. So the urethra has a couple different purposes for the male. But what about the length of a male urethra versus female? It's longer, right? Females are shorter. That makes females more prone to developing UTIs, urinary tract infections, which can lead to kidney problems, all that stuff. So just a couple of differences, how it works. There's a whole chapter we're going to talk about this stuff, so we'll go into detail later. Already talked about all that. Guys, this is your pH scale, talking about the amount of acidity in something, okay? This can be a little confusing because it kind of goes the opposite that you think it would, right? So our normal pH level in our body is anywhere between 7.35 and 7.45. That is a normal range for the human body. All right, those decimals, guys, you would think maybe if I had a change of a 7.45 to a 7.7, that's not that big of a difference, right? It's only decimals. That's massive. Guys, each of those decimal movements is like equivalent to like a 10,000% change in the acidity level in your body. Okay, so those decimals mean a big difference. So the lower the number goes, the higher the acidity level. Doesn't make sense, but that's how it is, right? If you have a pH of 3 point something, you're dead. All right, because guys, this gives you a little comparison. 7 even is neutral, it's water. It doesn't really have either, you know, positive or negative effect. The lower we go, 5 is black coffee. All right, urine sits around a 6, tomato juice is a 4, orange juice is a 3, vinegar is 2, stomach acid is a 1, battery acid is a 0. So imagine all of these things like coursing through your bloodstream and coming in contact with all of your organs. All right, the higher we go, the higher the number is, the less acidic your pH level is. So the more basic property we have. At the very end, the highest we can go is like Drano, drain cleaner. Okay, it has very basic properties. It becomes very corrosive in its own nature. We'll talk about that a little bit later. But yeah, baking soda, a Tums tablet, soapy water. So just right now, 7.35 to 7.45 is normal. That's neutral for our body. The lower the number, the higher the acid. We do not like to go outside of that normal range or we start to see big complications.
Does EMS ever take like pH blood and stuff like that?
We don't have the equipment to do it. But based on other things, other presentations, other assessments, I can tell you, I don't know what the number is, but they're super, super acidic. We'll talk about all of this later. We'll talk about all of that later. Holy shit balls, we made it. Okay. Oh, let me stop recording after I cussed. Sorry. All right, guys.